Good morning, everyone, and welcome. I think we're still waiting on a couple of people here, but it looks like we have a fairly full room, and in the interests of time, we should get started. So my name is Ben Kong. I'm a medical oncologist at Royal North Shore Hospital, and I feel like somewhat the new kid on the block here today. It's interesting to note the history of this event, and Dr. Hovey, who's sitting at the front here, has told us that this forum has been running either every year or twice a year since 2004, so that's just an amazing record. But this year, I guess, is particularly special given the events of last year, so it's really great to see everyone here, and we're glad that you could make it. There are obviously others who weren't able to make it today for various reasons, but nevertheless, it's excellent to see such a big crowd here, so we hope that everyone gets something out of today. Before I get started, I guess the first thing I'd like to do is to acknowledge BTAA, obviously, right on cue, as well as the New South Wales Neuro-Oncology group, supported by the Cancer Institute, who have guided and organised this event for many years. And we have a couple of people at the table here, no doubt, who many of you will know, Catherine Hindson, Dr. Liz Hovey, and unfortunately Kaye Duffy, who could not be here today, also played a large role in organising today's events. And of course I shouldn't forget Nikki Ramos at the Cancer Institute, who supports a lot of our activities. So, but we're glad for their support. So today's events will consist of as you can see on the program, patient information forum in the morning, a couple of medical experts, followed by a medical panel, and in the afternoon we'll be focusing on some more of the supportive care aspects. Just a couple of housekeeping details. Obviously everyone will have many questions today, and we do encourage everyone to hold over their questions to the medical panel. As part of our COVID safety commitment, we do have paper on each of the tables as well as pens. So what we'd like to do is, instead of using the roving microphone, to have everyone write down their questions on a piece of paper, and we'll collate those for the medical panel. On the note of COVID housekeeping, if you haven't already done so, please check in using the QR code, and if you need some assistance with that, please sing out. In the very unlikely event of an emergency, there is an emergency exit here, or obviously you can go out the front. And for those of you who haven't found them already, the toilets are just out the door to the right. So just before I hand over to Catherine, it goes without saying that these sorts of events would not happen without sponsors, both people to help in organising the event, but also financial support. And we have a number of supporters today of this event. In addition to BTAA and the New South Wales Neuro-Oncology group, we have had the ongoing support from the Brain Cancer group, or Care to Cure, as we would call it, Cure Brain Cancer, the Cancer Council, and of course the Cancer Institute. And last but not least, we've also had the support this year from the William Lazarus bequest, and I hope that Bill's family, who are sitting at the back here, won't mind us acknowledging their presence and support of this event, because as well as all the information that is provided today, this is also an excellent forum for patients and carers to feel like there's a sense of community here, which fortunately we've gotten back this year, and hopefully we don't have any interruptions to that with further COVID outbreaks. So with that note, I might hand over to Catherine. If there's anything I've missed, please fill in.
Did you feel a little bit upstage with what was going on? As you probably... I'm chair of this wonderful support group, and I can remember, I think I came to the first one of these meetings about 9 years ago, after my daughter was diagnosed with an anaplastic astrocytoma, and she's doing well. As a lot of you in this room may know, BTAA is involved in support and information. And if you go to our website, there's an enormous amount of information there. One of our committee members here keeps the website going with the latest stuff, etc. And we also have an 1800 number, and we send out information packs. So if you go on and register, if you haven't done that, you will get the latest e-news, which tells you about meetings like today. It tells you what's happening around the rest of Australia. And if you're linked to the IBTA, it also tells you what's happening overseas. They put out an e-news monthly, which talks about the latest research, etc., that's happening there. I'd also just like to say that the doctors, the New South Wales Neuro-Oncology group, that they give of their time freely every year. They actually organise this day. A few other people get involved, like myself, but without the doctors organising it, giving of their time and coming. And there's nowhere else in Australia that's actually does this. There are other forums that are organised by other people, but not an actual doctors group doing it. And I think we should be extremely grateful. When I answered the 1800 number back in December of last year, and it was a call from Christine Lazarus, and her husband Bill had died, and she wanted to donate money that would be from the funeral in his memory, and she wanted it to go to a brain tumour charity, but she also wanted it to be associated with Dr. Liz Hovey because of the care that had been given to Bill by Liz. And I had no hesitation in saying, well, I know what's passionate to her, and it's this forum. So we donated the money, they donated the money, and that bequest is now going to be spread out over the next several years at about $1,000 a year to help fund this day. And so I'd just like to say a huge thank you to you, Christine, for nominating us. And I think that's all I really need to say. And I'd like to hand back to Ben to start the day. And welcome, everyone.
Thanks, Catherine. So we have a couple of speakers this morning, and I think most of them probably need no introduction, so I've tried to find something interesting that you may not know about each of our speakers. Don't be too nervous. But we're going to have a couple of talks this morning. Firstly, Dr. Jonathon Parkinson will be speaking out surgery, Professor Michael Back about radiation therapy, and Dr. Hao-Wen Sim will give us a rundown of medical oncology. But to start this morning, we've got Dr. Jonathon Parkinson, who is a neurosurgeon at Royal North Shore Hospital and North Shore Private Hospital, amongst other things. Unlike some neurosurgeons, Jonathon is what the Americans would call a triple threat. He not just uses his scalpel, but he has also spent some time in the laboratory and understands a lot of the nuances of brain tumours. Unfortunately, I didn't have time to get Jonathon's bio from him directly before we came today, but a quick search of the internet reveals to me that he spent a little bit of time in Calgary during his fellowship. So I expect in addition to being an excellent neurosurgeon, he's an excellent skier or snowboarder, but perhaps he will enlighten us on that today in addition to talking about surgery for glioma. So thank you, Jonathon.
Thanks for that, Ben. I hadn't skied before I went to Calgary to do my fellowship, but I now love it as much as many others do. So I think you're on the money with that guess. I'd just sort of like to echo the sentiments of both Ben and Catherine about all of the behind-the-scenes stuff that goes on to put on a day like this. I've organised this forum myself in the past. I know it's a tremendous amount of work, so Ben, you deserve to be congratulated for getting the day together. And obviously, it's not something you do on your own. And not only am I grateful for the opportunity to speak, I'm really grateful that the opportunity for everyone to attend today exists. And I encourage you to thank the relevant people in the breaks. We were just joking at the table about the surgery talk is always first. The surgery always comes first in the journey for someone with a brain tumour. So I get to go first, and hopefully it's an act that everyone can follow. My kind of overview of my talk, some of the questions in the program that I'll address is about some general comments about surgery, the role of surgery, when the best time to resect is, talk a little bit about benign versus aggressive lesions, and then what to expect. So surgery for brain problems is not new. It was done in sort of prehistoric times, where there's skulls that have been found with evidence of healing after craniotomies, despite very, very primitive concepts of septic technique and anaesthetic and all those sorts of stuff. Obviously, what we're looking at now is a much more sort of modern way of approaching things, where we have these tumours that can look quite subtly different to the normal brain, how we go about surgery in such a way that's safe and that's in the patient's best interests. So there's a few key concepts for us to understand about surgery, and I try and educate my patients about this in terms of the way that we approach surgery and some of the thinking behind the sorts of operations we do, why we do them, and how we do them. So when tumours arise in the brain, there's really kind of two ways that they turn up. So it's either a very localised thing, something that's a lump, and quite obviously that's something that that if we can remove it, then that's very good, because the whole of the tumour is gone. Obviously, in the brain, we don't have the luxury of elsewhere in the body, and this is something I find myself saying every day, is that, in the bowel, if you have a tumour, you can take a foot of the bowel out and put it back together and you're fine. Or, anywhere else in the body, we can use the same sort of analogy. Whereas in the brain, obviously, it's high-priced real estate. So we have tumours that are diffuse, and yes, there may be a lump, but there's also cells that extend into the surrounding brain, and we can't remove all of the tissue because a lot of the tumour cells are in brain that's functioning normally. So our concept with surgery is then to kind of try and remove what we can. But surgery is always to some degree ineffective, because there's always tumour cells beyond what we can see. And this is a great graphic because it sort of shows a lump, and then there's some cells in the area around, and cells further away and further away. Okay, and this is why we work so effectively. We have to work effectively as a team, with radiation and with chemotherapy and other treatments to try and control what tumour is left behind. So then, if you think about it, then why do we operate at all, right? Like, if this isn't something that surgery is going to cure, then could we just rely on other treatments? And again, that's where a lot of the subtleties of different types of lesions and trying to predict based on imaging, and I'll talk about imaging again later on, how tumours are going to behave. So whether they're a low-grade lesion, something that grows slowly, or a high-grade lesion. Obviously, the location is a very, very important thing, and that'll be something I'll come back to as well. But ultimately, the main reason for surgery in some respects is getting some definitive pathology, finding out exactly what we're dealing with. And as much as we do have this sort of long list, this is from the most recent sort of pathology book that the WHO puts out, you know, we always have some idea what we're dealing with. Obviously, the subtleties are beyond what we can assess generally with scans, and even with evolution of scanning technology and different sorts of sequences like MR spectroscopy, things like that, we can predict more reliably, but there's always a bit of a guess. Now, a couple of things just to say about this. So first of all, you know, we've got this list of the different astrocytomas and oligodendrogliomas. And then the IDH status is important, that is something that many of you may have come across. But even within these groups, we know that tumours are going to behave differently, and that's because of the nature of these tumours being very, what we call heterogeneous, that different regions of the tumours behave different to other regions. So as time goes on, we're knowing more and more about, less and less to some degree, knowing how variable these tumours are. So obviously, getting pathology and getting tissue to be able to assess it and try and work out what treatments are going to be best, let alone what this is going to mean for the individual in question, becomes more and more important. So why do we operate? Well, like I say, primarily it's tissue sampling, finding out what we're dealing with. The second thing is what we call decreasing mass effect, okay? So that's where we have a lump in the brain, the skull's a box of a fixed size, you put something extra in there, it causes pressure, it causes problems. By reducing the mass effect, we can, you know, reduce headaches, things like that, okay? And that's how we can reduce symptoms. So often, it's not actually the tumour itself is invaded and is disturbing, for example, motor pathways, visual pathways, speech pathways. It's the pressure that it's causing that's causing the symptoms. There's also this principle about decreasing the cell number, or what we call cytoreduction. So if you think that there's less cells that the chemo or the radiation has to work on, then perhaps it's going to work better. And this is a very controversial kind of topic, and something that there's a lot of discussion about. And obviously the correlate of that is then, if reducing the mass effect and reducing the number of cells that the other treatments have to work on, does that mean that the bigger a resection we do, that's going to be better for the patient? But again, it really all comes down to location, and this graphic just shows a number of tumours all in different parts of the brain, some of which are in very dangerous spots, some of which are extensive, some of them form more of a lump that might be able to be removed, okay? So when we're talking about, you know, that then comes down to this big question that as surgeons we're always reflecting upon is, does resection help with survival in glioma? This is a bit of an old slide, but this is a table of studies, that some of which favour a more extensive resection and some of which do not favour any resection group. These studies are ongoing. So, you know, when we look at that graphically, there probably is a modest improvement in survival if we're able to remove all of the tumour. Now, I choose those words very carefully because it's often not a question of whether or not the surgeon's done a good job. Of course, I'm going to defend my kind, but it's also a question of the nature of the tumour, where it is, which part of the brain it's in, and whether that lends itself to being resected. So, what that always then comes down to is where the tumour is located. It becomes a compromise of the extent of resection versus leaving a patient with a neurological problem, okay? And this is something that's very, again, this is really, I think, the art of glioma surgery, is working out how much we can do without leaving anyone in a worse condition. Now, and that's because we know that one of the most important predictors of patients' outcome is their so-called performance score, or sort of what level of help they need, how mobile they are, and how they can get around. But obviously it just has a huge impact on quality of life, okay, if you have a deficit. Having said that, there are some tumours that are curable with surgery, and we need to predict that ahead of time. So this is an example of a patient I operated on 2 weeks ago. He has this tumour here in this, or had this tumour here in this deep location that looks very dangerous, and it is. The motor pathways on another scan I could see were pushed just to the back of it. Obviously this is high risk surgery. He'd had a previous biopsy, and this was a pilocytic astrocytoma, and that's a tumour that is basically curable with surgery. So this is someone that, rather than saying, I'll do a biopsy and I'll have a and I'll make sure that he's in good nick, and then over to Michael and Hao-Wen or the equivalents thereof. This was someone that I knew if I could do a good operation on him and remove all of the tumour, then, you know, he's likely to do very well, and thankfully he was intact after the surgery. And this goes, you know, we tend to focus this day on glioma, but this goes even further into other tumours, meningiomas, for example. This is a good example of a meningioma that's quite a large tumour at the base of the brain here. And knowing if I remove this, that's curative, then obviously that's going to affect my decision making going forward. But of course it comes back to that concept, this key concept of the lumps versus the diffuse problems. Okay. So then if we think about, if we have diffuse tumours, what are the kind of factors that we need to think about? Okay, so the accessibility of the tumour, the size of the tumour, and, you know, again, thinking about how long surgery might take, and we'll talk about that in awake craniotomy. We think about areas that we call eloquent brain, so things that are like speech area, motor, sensory, and other speech areas, and then the visual areas. There's quite clear definitions of where the tumour is. You know, what sort of mass effect it's causing, and then obviously the diagnosis. And again, even within that long list of pathologies, we know that some of the tumours are more likely to be sensitive to radiation, more sensitive to chemotherapy. Again, part of the art is, do I subtotally resect something with knowing that it's going to respond, again, to Michael, to Hao-Wen. But obviously my main thing is surgery and safety of surgery. Okay, so, you know, I obviously don't want to cause problems in the process of trying to improve things. And what are some of the things that we have at our disposal now to make surgery safer? Imaging is kind of the key thing. It's such a mainstay of neuro-oncology, and there's all sorts of different scans that have come on board. So the most common scan we see is the so-called gadolinium-enhanced T1-weighted imaging, which are those scans I've showed you where we see the white balls, basically, right? These tumours take up the contrast against the background of a T1-weighted brain image. MR spectroscopy, we talked about that a little bit. I mentioned that before. There are all sorts of patterns of uptake on, on the spectroscopy that are interesting and can help us not so much tell by and large between different types of tumours, but they can help us tell if things are tumours versus infection or versus demyelination, like MS, things like that. There is one particular type of MR spectroscopy which I've neglected to put in this slide, called 2HG spectroscopy, which is something for the IDH mutation, which I mentioned earlier. That's something that's having an increasing role. And I suspect over the next 5, 10, 20 years, we're going to see more and more of these so-called metabolites, the things that MR spectroscopy detects for, becoming important in tumour diagnosis. Functional MRI is a key thing, so where we have, and particularly with tumours where, as much as I can look, and you saw that graphic of the eloquent locations in the brain, and I can look and based on you know, anatomical knowledge, predict that these are areas that are important. Everyone is a little bit different, and sometimes tumours are pushing those areas away, and we don't know if we're pushing them forward or back or up or down. So an MRI where you're tapping your finger or generating verbs in your brain and those sorts of things can be helpful, and I'll show you a couple of examples. Diffusion tractography is a technique that we're starting to do some more work with at North Shore, where it looks at the tracts of the brain, so the visual tracts, the motor tracts, looks where they might be relative to the tumour, and again helps me think about how I might go about the surgery. And then intraoperative MRI, that has a role too, more really for extent of resection. And again, so for an intraoperative MRI to be useful. You have to kind of, I guess, buy into the sort of complete gross total resection kind of argument, which again is very controversial, and I won't dwell on, but it's another thing that's out there that people talk about. The biggest advance, however, is what's called frameless stereotaxy, okay, which, again, some of you will have had MRIs with these dots on your head that get then loaded up onto the computer, and using this little probe and this infrared camera, it tells us basically where we are on the skull or in the brain relative to the scan, because obviously, again, like somewhere else in the body, we can't feel where a lump is that we need to cut out. And so that can help us plan where we're going to make the craniotomy. We have this probe, have this camera, and the image is displayed on the screen, and that helps us know where to go. So that's a massive advance for us because of being able to find tumours and have some idea where the boundaries of tumours are. Neuroanesthesia the advances in that have been quite massive over the years. So in terms of using really short-acting, TIVA stands for total intravenous anaesthetic, so drugs like propofol and remifentanil that act really quickly. That helps us with the surgery. It helps us, again, in situations where we're doing things awake, keeping people out of pain and letting them wake up quickly if needed. But also that early post-operative period, it decreases complications because these things are not very long acting, so people are wide awake fairly shortly afterwards, and if they're not wide awake, it might mean it's a problem. Obviously, the different anticonvulsants that we use, it's been Dilantin for a long time, but Keppra on board the last sort of 10 or so years, and that the safety of Keppra has been a huge advance because it, particularly around the perioperative period and decreasing seizures, and then, awake craniotomy and the techniques that have gone along with that. When do we do awake craniotomies? Well, it's really about patient factors, so there's a little bit of picking the person who we think will be able to tolerate it, but it's mostly about tumour factors, which part of the brain, if it's near one of those eloquent locations, and then the pathology. We tend not to do as much awake surgery for higher grade problems because higher grade tumours look very different to normal brain, whereas even that example I showed at the start of the talk, it's very subtle, the difference between the tumour and the normal brain. So here's a couple of examples. This is the functional MRI, which shows where the motor cortex is relative to this, what was actually a brain metastasis. So that would be something we'd do asleep because we know that it's very, and again, brain mets also look very different to the normal brain usually. This patient had this lesion in his left frontal lobe, right-handed patient, speech is on the left side. But I thought it was a bit away from his speech area, and it was. So this patient had a resection under general anaesthetic, and it was an anaplastic astrocytoma. This patient, however, a bit different. This is also in the frontal lobe, but it also goes down to the part of the brain called the insular cortex. He had a functional MRI. This is now a coronal image, so it's just above where the tumour is. So I was able to remove a lot of the tumour away from where the speech area is first, moving towards the speech area and then stopping when he started to have some speech problems. I left that component in the insular cortex, and that was also an anaplastic astrocytoma. And you can see this is where the hole was, and this is after radiation, where even all this sort of darkness here that was the tumours really shrunk away with radiation. We still get faced with these sort of problems where it's a deep tumour going across the corpus callosum, it's on both sides, it makes it very difficult to resect. We can either remove part of the tumour, and we try to where we can because that reduces mass effect, but sometimes that we worry about doing that because of the risk of bleeding from the tumour that's left. So there's still a role for stereotactic biopsy. This is an example with a patient in a frame. Sometimes we do it frameless as well. But these are the situation where we, for want of a better way of saying it, kind of cut our losses and say, well, we can't remove a huge amount of this tumour. Let's keep the patient in good clinical condition and then over to the rest of the team and for the treatment. So to summarise what we think about surgery, it's the primary aim is to obtain a diagnosis, okay? Obviously, we want to treat mass effect and remove the bulk where we can. And the location of the tumour is a critical factor. Obviously, as well as what we think the pathology is going to be based on those advanced imaging techniques, based on patient factors as well, age, gender, tumour location. And there's always a number of options for surgery. And the other question, I guess, is will I have surgery again? You know, obviously we talked about the order. It tends to be that, you know, I do an operation and Michael and Hao-Wen do their treatments. I often come back into the picture. You know, there's a number of variables in terms of the pathology, in terms of other treatments. So sometimes other treatments can cause what we call treatment effect, or there can be contraindications to further surgery with some treatments like Avastin. And then, you know, basically patient factors such as the clinical, you know, condition of the patient, and other tumour factors. So where do I see my role, and what's the role of the neurosurgeon? We're kind of at the start of the process. It's obviously a very dramatic time. It's a scary time for patients and their families. And, you know, it's a real privilege to be able to be part of that and to offer the support I can. Obviously, we're the ones making the diagnosis based on the radiology and histopathology, and then, you know, follow up basically for re-resection. And as far as we've gone, things continue to evolve, and you know, I look forward to seeing the advances that we make with surgery over the next few years. Thank you very much, and I think we're holding questions till the panel. Is that the plan? Okay, thank you.
Thanks, Jonathan. I'm sure that many of you have questions, so please don't forget to write those down, and we'll collate those later for the panel. That was an excellent talk, Jonathan, and certainly a reminder to me of how specialised some of these skill sets are that our practitioners have, and what a team effort it is to look after patients with brain tumours. So next up, we'll have Professor Michael Back to give us a bit of an update on radiation therapy and also some neuroimaging modalities following on from Jonathan's talk. Michael is probably well known to many of you. He's an English football fanatic who masquerades as a radiation oncologist in the Northern Sydney Health District and treats patients at many different locations. So I'll leave it up to Michael to tell us a bit about the latest in radiation therapy.
Thank you, and it's important to note that the Gunners got up 2-1 this morning, a goal in the 91st minute. I saw it on the train between Gordon and Kalara, so it was quite a... We still need a win this weekend, last round. We need Tottenham to lose, which for any Arsenal fan is always the case. Okay, let me see if I can work this. That's the topic of the talk today. I'm a radiation oncologist from the Northern Sydney Cancer Centre and also Central Coast Cancer Centre as well, and some units around Genesis Care. The aspect for today's talk was basics of radiation treatment, neuroimaging modalities. I thought I'd just roll on to what's important to know, where radiation has changed, and why you should feel more confident going into treatment now. So what's radiotherapy? So what's radiation treatment? Essentially, it's the use of high energy X-rays to treat cancer. The same type of X-rays you have when you get a chest X-ray, but these are more powerful. So they don't just take a picture, but they can actually damage cells. The key to it is that it's targeted and precise, and it's given on a machine called a linear accelerator. For people with gliomas in Australia, that would be probably 99.5% of the people would be treated on a linear accelerator. The treatment is individualized, so it's a treatment which is targeted to where the site in the brain is. So it's not a generalized treatment, it's actually one which requires individual planning. And the key aspect of it is that we damage tumour cells, but by giving it in certain ways, either by sparing the tissues outside of the radiation field, we can actually protect the normal cells, and by giving it slowly, we can actually allow the normal cells to repair or recover or minimize the damage. Now, that's the basis of it. I think I've jumped straight to what my 3 tips to patients are. And the 3 tips are regarding radiation treatment is 1, generally how you walk into the radiotherapy program is generally how you should tolerate it. So it's really important for John to understand that. So if you get through John's operation okay, then you generally will get through the radiation component reasonably well. We want John to take out as much tumour as possible. This is for gliomas, and the same principles apply for metastases as well. Get out as much tumour as possible and create a space, but without causing damage. If a patient unfortunately comes through an operation with damage, then they're really in more difficulty when it comes through for treatment. So aggressive surgery up front to clear out everything, if it means causing damage, will have a negative effect down the track, and that has an impact on overall prognosis. The other fact is that this is as I said, individualised treatment, so the side effects are really dependent upon what site in the brain where the tumour is sitting, and generally comes down to swelling, and swelling, and swelling. It's really the biggest component. So radiation treatment can make you tired and can cause a lethargy, especially when we're giving it in combination with the oral chemotherapy. But the biggest factor we have is swelling, where tumour cells, it's not the normal brain that swells up, it's the tumour cells around the area where the surgery's been or where the tumour's sitting. They swell and become inflamed. It's a process of inflammation. And that's when things like steroids, which are anti-inflammatories, come in to try to settle that down. But you can think of multiple different potential side effects of radiation, but that is really the key one. That's the one we concentrate on most. And we do our best to try to manage that and have this dance between having a high dose of steroids to reduce down swelling, a lower dose to manage the side effects of steroids, and try to find the right balance in between. With time, swelling will eventually resolve, but sometimes we don't have that time and we have to do other things. And the final tip is mobility is the key. So if I say to our younger patients, if you're not working, you're walking. You've got to do it. It's like taking your Keppra. You have your Keppra morning and evening, you'll have your walking morning and evening. If you can't walk, then we need Andrew Cole, who's talking later on this afternoon, to really work hard in rehab, or give you some mobility aids, or do something to compensate for the mobility issues. But we have to keep you walking. If you're not walking, then you lose muscle bulk. Steroids makes you lose muscle bulk. Swelling leads to weakness, which leads to increased steroids, which leads to muscle bulk loss, which increases weakness. So the key aspect is maintaining your muscle bulk, not necessarily through diet, but mobility. So if you're walking and you're mobile, you not only enjoy life better, but you'll live longer. And that becomes a key, not only for brain tumours, but also in patients with other malignancies elsewhere around the body as well. So what I thought I'd do is break down the radiotherapy pathway and where the radiation therapy comes into play along the journey that many of you are on, or have been partly on so far. And it comes down to a process of following decision-making for radiotherapy through to follow-up. And then there's 3 key steps which will help you decide if you want to have radiation treatment, if you're offered radiation treatment, how it should be given, where it should be, etc. The 3 aspects are really target decision. You've got to map out the tumour. We've got to know where it is. That's the most important part of the treatment delivery. You don't need the Rolls Royce to deliver it. You need to have the correct road and the correct map to drive it on. So you need to map it out effectively. The next step is you've got to have really good planning. So you've got to be able to hit that target, but minimise the dose elsewhere. And the final thing is you've got to have good, safe delivery, but you don't necessarily need the Rolls Royce for delivery. So the first aspect is this aspect of target volume delineation, or just designing or working out where the tumour is. And John mentioned all about the MRI scans, and we can look at those sort of aspects. And that's much more part of what we do now. The preparation for treatment is key. Trying to get the right design of the treatment and target exactly where it is why we order so many scans beforehand. And as we go further, you'll be on the MRI machine not for 15 minutes, you'll be on the MRI machine for 25 minutes and sometimes 45 minutes because we're going to be doing different sequences to help map out where the tumour is. We have the ability to target the treatment now and hit that area, but we've got to scoot the dose around normal tissues and reduce the amount of good normal brain we're treating. So we use a combination of MRI scans and PET scans. I don't have a pointer, so it's going to be quite difficult. Anyway, so basically, if you look at the MRIs, you point out that John showed beforehand, that's on the far side. That gives us a clue where their tumour is, but there's a bit of grey here, a bit of white there, a bit of grey there. Then we need other sequences of the MRI to determine what's tumour and what might be scar tissue or inflammation. And we also do PET scans, which can potentially, if we're lucky, this is a PET scan for a meningioma, which can light up right where there are sites of residual disease. And then from there, as a radiation oncologist, we can try to map out the extent of the tumour. They don't grow like that. They don't grow like spheres. They grow along pathways in the brain. They grow asymmetrically. So as John pointed out there, the tumour from the lump might be 4 centimetres away, but it may be 4 centimetres away in a certain direction. It may not be 4 centimetres away all around the tumour. So part of the clues that we've got to work out is find out where things are going and try to track where that tumour is heading. And then if we can track where it is and we know where it is, then we can deliver a dose which is pretty much confined to that area to a high dose. So we need the knowledge. And this is where we're really changing a fair bit. We're getting much more better understanding of the way that the tumours move in the brain as we're seeing better and better MRI imaging. That's an example of a DTI and tractography. So where the textbook shows where things are. Second slide is one of our patients with a tumour there. And the third slice is right where the tumour is growing. It's growing right along one of those green roads or blue roads that we're seeing there. It's not extending 5 millimetres that way, but it's extending 4 centimetres in that direction. So that will allow us not to treat large amounts of brain, but to work out exactly where that tumour is going and hit that area in a much more sophisticated manner. And that leads to that second factor, which is the planning. And that planning is trying to design the treatment and push the dose right where the tumour is, but spare the normal cells. And so this is an example of just what modern planning does now. In the old days, when we used to treat patients, we would like to have a nice even dose across the whole tumour area. You didn't want what we used to call a microwave oven effect, where you heat up something and you get a bit of hot here and a bit of cold here. That was deemed to be bad radiotherapy. But now in 2021, we're managing patients with hot areas here, colder areas here, and we're getting more clues from the MRI as to where to deposit dose. And at the same time, swing that dose away from the good cells and the important structures in the brain. We can allow some of these structures, and so right in the middle there, we've got the brainstem, so allow the brainstem to get part of the dose, it can tolerate that, but we don't want it to get the really high dose. So right where that red is merging into yellow, in the past, to deliver with a standard treatment, it'd all be blue, and you'd be underdosing the tumour in that area. So the technology has changed, not on the machine, but in the software to allow us to hit that area. We're still using the same recipe, but we're getting better dose in, and soon we should be able to push that dose up a lot higher. And what we do, what we call dose escalate the area, so give a higher dose. When we first started treating prostate cancer, when I was a specialist treating prostate cancer, we used to give 60 units of radiation to prostate cancer. We now give 84. And our results with prostate cancer have improved. In the brain, we're nervous about that because of swelling. So if we can manage the swelling better, then we can potentially push the dose up a bit higher. And the technology and the imaging is allowing us to do that. So that's an example of what I used to do. So I'm a fairly young man. And I used to do this to people back in my first job in 1996 as a specialist, where I couldn't order an MRI. I wasn't allowed to order an MRI back then. We had to admit people into hospital to get an MRI done. And then we used to do a plain X-ray, and then we get out the old protractor and draw circles. And it'd be one beam there and one beam there, and that'd be it. Then we got smart, and we went to 3D conformal. And I was really proud of this. I actually got this off a slide of emerging technologies, a talk I gave in Shanghai in 2004. And I was really proud of that slide. But also what that showed was that there's a lot of blue on the other side of the brain, and the shape of the red is pretty much a rectangle. Tumours don't grow as rectangles, but we're treating all that area to a really high dose. We've gone from 3D conformal now, which used to take, a therapist manually 24 hours to do. Now we go through to what we call intensity modulated radiotherapy, where we can design whatever we want and they can punch that out in an hour. And we've actually got machines now which can change the plan on the bed whilst you're just based on an image done on the bed. So it can be changed within 3 or 4 minutes. So we're able to now push dose into areas of the brain where we couldn't before at a higher level, and also protect good areas. So we can design the treatments in different ways. And that leads to a lot more potential options in the future for our patients with dose escalation based upon interesting aspects we see from PET scans and MRIs. Our key is not to improve the radiotherapy machines, but to get the MRIs better and to get the PET scans better and to get those metabolites that John was talking about in a better way. The final thing is the machine. And I'm going to be a bit derogatory here because everyone looks for the machine. The machines are high quality. In Australia, we've got a national organisation which every year checks your machines to make sure they're delivering a really accurate dose. And every day, the physicists in the department check the machines The machines can deliver things much, much better than what they could do in the past. But the machine technology is just about there. It can do more interesting things for targets that move on the bed, but brain tumours don't move. The key now is actually the step beforehand, making sure we're hitting the right areas. So that is a standard linear accelerator. That's one at Gosford Hospital. So most of the work for linear accelerators now goes into the roof. You've got to make the ceiling look nice because the machine's pretty much the same. And so 99.9% of our patients across Australia will be treated on a linear accelerator. It has the ability to do a CT scan on the bed, and it gives the beam very accurately. That's a gamma knife. So gamma knife is a really novel, interesting machine that came through from about the 1970s, and there's 2 in Australia. Gamma knives are really good for very small targets. The linear accelerator can treat those very small targets as well, but it also treats the workhorse. This very small target treatment is what we use for brain metastases, and that's called stereotactic radiosurgery. The gamma knife is a machine dedicated for that. And basically, you screw a head frame in, and the beams just, they're radioactive sources that allow beam to go straight through, and you can target it very much into the centre. But the other machines can do that as well. This is really good if you've got Parkinson's disease or if you've got some sort of pain neuralgia where you can give a really, really, really high dose to try to destroy that part of the brain. Not a lot of additional advantages over standard linear accelerators for brain metastases, and no use in gliomas because the targets are too big. That's a proton machine, and they also look really good too. And there's one coming in Adelaide in 2022, and the federal budget just pushed up a little bit more funds to pay for patients to have that. Protons probably don't have a great role in gliomas. We thought they would, but it's going to be a fairly limited role, if any. And I don't think the Medicare indications will cover proton therapy for gliomas up front. Protons have the ability to dump the dose very quickly and then drop it off very far away very quickly, so getting minimal dose to your normal tissues. So the one over there shows the red circles as we saw before, and the rest of the brain looking pretty clear. That's what a proton does. The IMRT splashes a bit of dose in the surrounding brain. But protons have a bit of an issue because you're pushing it all in one area. So for people with brain tumours, there's probably going to be a higher risk of permanent hair loss on that side. And also, we're knowing from what John was saying, we need a bit of dose going down those tracks and pathways. And so if we cut it off, then we're probably not going to be able to deliver that because we're not getting some of the advantages we get. The bottom line is that it actually these machines need smart humans to run it. That's where the key is. So what's the most important parts of that pathway for you to understand? For patients with primary tumours, it's really the target design and the follow-up. The follow-up's the key. I can design treatment, and to design a course of treatment, for me sitting in front of a computer for about an hour just doing a whole lot of drawing in different colours. But the key in longer term, and the most time we spend with our patients, is actually working out what that swollen area is in the brain, and if it's tumour regrowth or if it's just a whole lot of swelling as a result of the treatment. So we have to map it out to where we've been before. The poor radiologists see your scans after treatment and just scratch their head. They don't know what's happening. So you actually need your radiation oncologist or your medical oncologist or your surgeon to interpret and understand that. And we see bizarre things in the brains. This is not an unusual thing. This is a patient going from left to right over time, and she's got a swollen area near the surgical cavity that came up. We thought it was going to be recurrence, and then disappeared. It was just swelling. It got better on its own. Or we have to treat a big swollen area with a drug called Avastin, which helps to get it down as well. But we need to be able to interpret those changes. So follow-up is the key. For patients with brain metastases, it's more about the decision-making up front and also getting the software right, so you're hitting that area and sparing the surrounding brain. So with brain metastases, we used to treat everyone with whole brain radiotherapy, which, if they had 1 or 2 lesions, they would get the whole rest of the brain managed. But that whole brain treatment often led to late side effects where there was scar tissue in the brain. So we've moved away from that now, and the key now is to just spot weld the lesions as they come up. And it might mean that in one sitting you just have one treatment to 2 lesions, and then you come back a month later after another MRI, if there's another one, you spot weld that. And you manage patients under a policy of whole brain radiotherapy avoidance. And we've got some really, really nice software which can do that now, where patients used to be on the bed for about an hour to get 5 or 6 different lesions treated. Now it can be all over in 10 minutes. So, and without any need to screw a head frame in, you could just use a basic mask. So that's the pathway for radiotherapy, and that's the roles that we see in radiation therapy across the continuum of how we treat people. And I guess part of it comes down to knowing that things have changed over years, where those initial images, when I was a young man treating people, targeting in that area there, we're now basing some of our decision making off the results of those treatments. So late side effects in the brain are based upon old studies performed in the 1990s. We need to move along that and gather more information, use the good imaging to help design our treatments, and get up and coming information about how our patients are managing or functioning in the years after treatment. And that was from last Saturday's Loonig, which was probably a bit about decision making. Which way? There must be a path there, and hopefully these sessions will help people decide which is the most appropriate way for them to be managed. Thank you.
Thanks for that excellent summary, Michael. When Michael was a young man, I was still in high school, and so hopefully one day I'll be able to get up and talk about the things that we do today as though they're ancient history, and talk about excellent new treatments that we'll have in the future. Our last speaker this morning's going to do exactly that and tell us a little bit about what's going on at the moment in medical oncology and what's coming up in the future. Dr. Hao-Wen Sim is a medical oncologist at Chris O'Brien Lifehouse, as well as the Kinghorn Cancer Centre, and he also happens to be the clinical lead for the Neuro-Oncology, the Cooperative Group for Neuro-Oncology, got to get it right, which is also known as COGNO, and is involved in clinical trial design. So welcome to the stage, Hao-Wen. I don't have much dirt on Hao-Wen because he's squeaky clean, but hopefully one of you can dig up something interesting about him during the break. Thank you.
Thank you, Ben. So my area of expertise is medical oncology, and this is where we focus on drug-based therapies. These are the whole body or systemic therapies. This is a great complement to the surgery and the radiotherapy where we focus on sort of localized treatment. That was discussed by Jonathon and Michael just before. We're looking to treat, I guess, the whole of the brain, what's left behind. Just by way of further background, I guess in general our management approach depends on the type of tumour we're treating, and that's often based on the cell origin of the cancer and also by the grading. And just to simplify things, this is just a schematic of some of the key cells within the brain. We obviously have the nerve cells, those neurons, but supporting these neurons are what we call glial cells, the support cells. And one of the key ones are these so-called astrocytes. They interface between the neurons and the surrounding blood vessels and environment, and very important for providing nutrition to those neurons. Tumours which arise from these astrocytes are called astrocytomas. And another key cell within the brain are these oligodendrocytes, and they have a different function. These blue cells, they wrap around those nerve fibers and provide insulation. And this is very important to allow those nerve signals to conduct down those nerves efficiently. And tumours that arise from the oligodendrocytes, we call them oligodendrogliomas. And then Jonathon alluded to this before, this idea of grade or aggressiveness. Grade 1 tumours are much less aggressive. Grade 4 tumours are aggressive and actively dividing. And the concept here is a grade 1 tumour, these cells look much more similar to normal brain cells, and grade 4 tumours are much more bizarre and very different. And grade 4 tumours are much more likely to grow quickly. And so we combine these concepts between the cell of origin and the grade, and we come up with the specific sort of diagnostic terms. This is a simplification, but you have at the top the grade 1s going down to grade 4. Grade 4 tumours are the glioblastomas, which unfortunately are the most common form in adults. And then in terms of naming, the astrocytomas, if they arise from the astrocytes versus the oligodendrogliomas, if they arose from the oligodendrocytes instead. I guess over the past 4 or 5 years, we have supplemented this with increased knowledge about the molecular characteristics of these tumours. For example, we know with the polycytic astrocytomas, a large proportion of these will have a particular aberration in the BRAF gene. And this is interesting because we have specific drugs that can target this if this is present. With the oligodendrogliomas, instead of just looking under the microscope to see whether it seems to be coming from one of these cells, there's a specific aberration called a 1p19q co-deletion, which tells the pathology that this is an oligodendroglioma. And then, although glioblastomas, typically we diagnose them based on this grade 4 appearance under the microscope, we now know that even if a tumour looks a little bit less aggressive, say grade 2 or 3, if they harbour some of these adverse molecular features that you can see at the bottom, for example, if they have a normal IDH gene, but they have these sort of chromosomal or TERT EGFR aberrations, that they may behave more aggressively and more similar to a standard glioblastoma. And the significance of this is that we may be inclined to treat them more like a glioblastoma rather than a low-grade glioma, despite the appearance under the microscope. And so with this schematic, this is kind of how we decide how intensively we'll treat these tumours. The lower grade tumours are more likely to be I guess, more localized, so surgery and radiotherapy are more the mainstay. And then as you move towards the more aggressive glioblastoma, which tends to be very diffuse in nature, we need to sort of throw in the whole package and do surgery, combined radiotherapy and chemotherapy, followed by further chemotherapy. So this gives some guide as to why we have this sort of multimodal approach. Again, this concept of diffuse that Jonathon alluded to right at the beginning, this is an electron microscope appearance of gloma cells in green. You can see that there is a central core of cancer cells, but they are spread out and quite diffuse. And the concept here is that you might take out the main tumor bulk with surgery. You might supplement that then with some radiotherapy to that surgical cavity region, but you're still going to have these cancer cells away from the primary site. It's really hard to mop up every single cell. And this is kind of where the drug-based therapies come in. We're trying to treat more diffusely through the brain with these drugs. In terms of the drugs that we have, the mainstay, really since at least 2005, has been this drug called temozolomide. This is what we call a survival curve from that pivotal paper back in 2005 by Stoop and colleagues, where patients underwent surgery followed by either radiotherapy alone or radiotherapy with the addition of temozolomide. And survival curve, basically the vertical axis shows the proportion of people who are still alive at a particular time point. And we can see in the blue that with the combination, that survival curve is lifted upwards, which is a favorable thing. And just to give a guide, you can see that this is back in 2005, in terms of the time point for 50% of people to still be alive with the radiation alone was about sort of 12 months, and then when you added the temozolomide, maybe 14 to 15 months. But I guess what was even more interesting to us is that you can see that sort of long tail where in blue, it actually stretches it out more towards 5 years. There is a small group, maybe sort of 2 to 5%, who will still be doing well at that point. And so although we have this aggressive, incurable, very nasty glioblastoma, there is a very small subset that with maximal therapy, there is some hope that they could do well, albeit that is the minority still at this point. Some of you may be familiar with this idea of MGMT promoter methylation, that now with glioblastomas, we tend to subdivide them into those which have this methylation and those which are unmethylated. And the significance here is that if you do have this favorable methylation, irrespective of the treatment you get, you tend to do slightly better than those who have an unmethylated MGMT promoter. And also within those groups, the separation between those two curves, that perhaps adding the temozolomide is slightly more advantageous in that group where you are methylated, that might be a particularly responsive group. And in terms of what this is, methylation basically means to turn off or silence. So if you have methylation of the MGMT promoter, the tumor cell is making less MGMT. And MGMT is a DNA repair enzyme, and so if it's turned off and it's not present, the tumor can't repair DNA damage as effectively. And so when you give temozolomide, the tumor gets damaged, it's not able to repair as quickly. So we think these tumors are more likely to respond well to treatment such as temozolomide. So this is generally a favorable thing to have. And I guess the core drug temozolomide, why did we pick this? This is a drug that's a very small molecule. It can be taken as a capsule because it can be absorbed through the gut, but also can be absorbed effectively through those tight junctions in the brain and get into the tumor. And inside the tumor, it then gets into the DNA and forms cross-links, which prevents these cells from effectively dividing. We still give temozolomide with this standard regimen where you have the radiotherapy typically between 3 to 6 weeks, and we give daily temozolomide alongside that. You have a 4-week break, and then we have further monthly cycles of temozolomide where for 5 days, every 28 days, you get some further chemo. And the principle here with the monthly chemotherapy is that you cause some damage, both to the tumor and slightly to the normal cells, and then during that gap, the normal cells should have a chance to repair themselves. The cancer cells have that defective repair. Hopefully they can't repair to the same degree. And you sort of repeat that. And at the moment, typically most of us will treat for sort of up to 6 months, and we will then reassess how you're going at that point. I guess in terms of other drugs, I mean, once temozolomide is no longer effective, if there are no sort of other good local regional options, such as further surgery or re-irradiation, what other drugs do we have? Probably the two other drugs that are fairly commonly used at the moment would be lomustine, bevacizumab, or the combination of the two. This is just, again, from another paper showing the survival curves, comparing the combination of lomustine and bevacizumab versus lomustine alone. Potentially with the combination, the time to further tumour growth might be delayed, but the overall sort of survival outcomes still look to be fairly similar in this particular study. And so I think your doctor may, for different reasons, prescribe one drug or the other or the combination. Bevacizumab is quite a different type of drug. It's not a standard chemotherapy. Bevacizumab works by actually targeting a growth factor for blood vessels called VEGF, vascular endothelial growth factor. And the concept here is that instead of directly attacking the tumour, you're trying to stop the growth of abnormal blood vessels that feed these tumours and deprive these tumours of the key nutrients they need to grow and divide rapidly. And bevacizumab might have particular advantage when you're worried about swelling. The other advantage is that it helps to shut down that leakiness of the blood vessels. And so perhaps we might be more inclined to try bevacizumab if we thought there was a component of swelling, if a patient needs a lot of steroids and you can't wean that down successfully. Bevacizumab might be particularly useful, whereas lomustine is much more similar to temozolomide, that more standard sort of cytotoxic killing chemotherapy. And so there might be advantages of one versus the other. Sometimes we might give the combination. And so that has been our key armamentarium. Still in 2021, in terms of drug-based therapies, we have temozolomide, lomustine, bevacizumab, potentially interlinked with further surgery or radiotherapy, depending on the situation. And that might seem a bit depressing. That's just our limited arsenal at the moment. But I guess where are we going to, and where's the hope going forwards? One of the key ideas here is the possibility of personalized therapy. And this is trying to find something unique about your particular glioblastoma, and we can find some unique mutation. Maybe we have a drug that can target that in a much more specific way compared to the whole body sort of chemotherapy. There are a few programs that have been helping us to do this. One of them is called the MOST program, been run through the Garvan Institute, but it's a national program where in tumours, including brain tumours, where you have sort of gone through the standard treatments, we don't have many options left. They will take these tumours and do genomic profiling for us, trying to identify something that might be unique about that tumour. We recently also ran a pilot study called LUMOS, and this focused more on the lower grade 2 or 3, the diffuse or the anaplastic gliomas, where in people who need repeat surgery, we took that tissue and looked at the genetic makeup at that point and then tried to find unique targets that we could help guide further treatment at that time point. And I guess in terms of the targets that we may be looking for, we know that particularly with those lower grade 2 or 3 gliomas, a large proportion of them will have this IDH mutation. And there are a group of drugs that are being developed at the moment in various stages of trials trying to effectively block this IDH mutation, and so that might be a potential targeted therapy. Some of these tumours, a very small proportion, have this thing called an NTRK alteration, and we have some drugs that can actually target this quite effectively. At the moment, if we know that your tumour has this, the most have a sub-study that allows to access larotrectinib. And then there are a range of other potential growth pathways that we sometimes find, and I guess there's a whole group of drugs that have been developed trying to block these individual pathways. Now, sometimes it's not that straightforward. A tumour may have several pathways that are working simultaneously, so maybe blocking one pathway may not be sufficient to control the tumour growth. And the other condition here is that we need drugs that can effectively get into the brain, and so that does limit some of our options. So that's one sort of area of advanced. Another key area that we're looking at would be these immune-based therapies, and the concept here is that instead of targeting these cancer cells directly, we try to harness the strength of the immune system. And basically we're trying to upregulate the immune system to recognize the cancer for us and then use the immune therapy arsenal to attack it directly, or sort of indirectly, having sort of primed the immune system in advance. An example of this is we had a trial called Nutmeg, a national trial looking at a drug called nivolumab, which is a PD-1 blocker. PD-1 is what we call an immune checkpoint. And the idea of blocking this immune checkpoint is that we sort of turn off one of the brakes on the immune system and make the immune system much more active. And hopefully, by turning off the brakes and getting the immune system to recognize the cancer, we can have this potential durable benefit where the immune system continues to be dynamic and continue to recognize the tumor. Now, admittedly, this has been very successful in some other tumor types, such as melanoma, and now sort of lung and bladder, head and neck, and a range of other tumors. We haven't had as much success to date with this more standard strategy. And so there are a range of other types of immune therapy that people are looking at. This is more in the preclinical or early clinical phases, so still some work to do, but these are interesting and exciting areas that we're looking at. There was a paper published about 2.5 years ago in one of our big journals looking at a form of modified poliovirus. Polio is a virus that can naturally get into the central nervous system quite effectively, and what they did is modified it so that instead of causing polio, it actually helped to attack these glioma tumor cells. The survival curve on the right is, these are patients who had recurrent glioblastoma. And although the majority still did not have much benefit from this, you can see this interesting phenomenon where with those who had the modified poliovirus, there is a proportion who, sort of stretching out to 5 years from recurrence, still seemingly doing very well. Now, this is very small numbers, but it was exciting, and there's actually a whole range of modified viruses in development in various stages at this point. There's no limit to creativity. Vaccines are very topical at the moment. There have been attempts for a long time to create vaccines against targets that are unique to the glioma tumor cells. There's this group of treatments called dendritic cell therapy. Dendritic cells are cells that are important for surveilling the environment, trying to find infection or foreign cells in the body. And the idea here is that you take out the person's dendritic cells. In the lab, you then prime them against unique proteins in the tumor, and then you reinfuse these dendritic cells. Hopefully, these activated dendritic cells can then turn on the rest of the immune system. And then you also have this group of sort of modified T cells, whether that be sort of CAR T cells or BiTE cells. There's a range of T cell technologies. And again, the idea here is that you take out the person's T cells, and then outside in the lab, you modify them in some way to directly attack the cancer and reinfuse them. The T cells are sort of the key effector cells of the adaptive immune response. And so if you can modify them in a particular way, maybe that will then leverage that immune attack response. Another area that has been of great interest is this concept of the blood-brain barrier, that one of the limitations in terms of why we only have a few treatments available at the moment is that many drugs that we think might be useful in the lab can't get into the brain very effectively. One of the potential concepts is to use this thing called focused ultrasonography. Basically, you inject some microbubbles, and then over the region of the tumor, you'll shoot some ultrasound waves, and these bubbles will expand, and they'll cause temporary disruption of the blood-brain barrier. And the idea is to try to give the drug during this period of temporary disruption, so you can get maximum sort of diffusion into the tumor, and then that disruption will naturally heal. There's also these group of treatments called nanoparticles. So if a drug can't naturally get into the brain, perhaps another strategy is to package it within sort of a carrier protein, which can get into the brain. So this carrier protein will get the drug from the bloodstream into the tumor cell, where it will then be released, and then the drug can do what it needs to do. So this is sort of a transport vessel. There was some news recently about sort of silver line nanoparticles, and actually a whole range of these are in the works. And again, this is very interesting and exciting. There's sort of preclinical models demonstrating that this seems to be a viable strategy, but at least to my knowledge, we haven't really got into serious clinical trials at this point. So still some work to be done. And the final aspect is really the idea of efficiency of clinical trials. It's been a long time. Temozolomide was sort of set up in 2005, and now in 2021, haven't made too many advances since then. And the older strategy has been to really do one sort of big trial, one after another, go for phase 1, 2, 3, try one drug. If not successful, you try again, going through this sort of sequential strategy. I guess that's not very time efficient. And what we're trying to do now is be a bit smart and have these so-called sort of adaptive or platform trials where you can ask many research questions simultaneously using the same set of patients. And thus you can try to ask more questions and potentially assess more drugs more quickly. And hopefully we can therefore work out whether a drug is useful or not. If not, we move on to the next one and get through that cycle much more quickly. MAGMA is a trial that's going to be available. It's been set up across Australia for patients with newly diagnosed glioblastoma. At the moment, there are two particular research questions looking at the timing and duration of temozolomide. But the concept of the platform is that as new research questions come up, they can be added to the platform over time dynamically. As certain questions are answered, they will be removed from the protocol. So the idea of this is that this will be a rolling platform that keeps going, which provides a trial infrastructure for questions to be asked along the way. And so I guess, where's the hope going forward in terms of, drug-based therapies? I think these are, to me, the 4 areas of great interest. The idea of having personalized therapy, the idea of using the immune system, ways of expanding our options in terms of drugs by breaching that blood-brain barrier, and finally, by using modern trial methodology to more efficiently answer some of these questions. And hopefully with the combination of these, we might start making some additional advances. And I think we'll probably leave questions to a little bit later on.
Thanks, Hao-Wen, for that excellent summary of what is obviously an evolving area. You can probably see what literally keeps Hao-Wen up every night. I often get emails from him at 2 o'clock in the morning, and this is why he's up thinking about all this sort of stuff every night. So a lot of work to do in the future. We're going to take a little bit of a break now. We're only a tiny bit behind time, but we thought we might take a couple of extra minutes. On the program, it says that we're going to come back from morning tea at 11:05, but I think we can stretch that out a little bit just to 11:10 to give everyone a little bit of a chance to mingle. Don't forget that during the break, a couple of our sponsors have tables outside, so please feel free to go and pick up some more information, have a chat, and importantly, we're all on a first name basis here. I can see everyone's got their name tags. As well as all of our presenters here, we do have a couple of people from the, if you don't mind me singling you out, guys, from a Neuro-Oncology cooperative group. So this is a great chance to sort of see some new faces and have a talk to anyone you want to introduce yourself to. The last thing is with questions. I encourage you to all write your questions on the paper that Catherine's holding up there, and there's pens at each table. I'm going to lean on Dr. Hovey and some of the others to perhaps collect some of those questions, so feel free to write them down and leave them on your table, and we'll collate all of those for the panel. If possible, if you can try and keep your questions as generic as possible. I know everyone's probably got questions about their individual treatment and so on, but we do have a wide-ranging panel here, so if you can try and keep your questions for the panel, that would be great. But otherwise, we'll see you back at 11:10.
Prince of Wales, and also work at University of New South Wales, and have been very involved with COGNO, which many of the panellists have been involved with as well. And a huge thanks again to our sponsors and to the people behind the scenes, such as Kaye Duffy and also Nikki Ramos from the Cancer Institute. So you've heard the speakers this morning. So we've got Michael Back, radiation oncologist, Parkinson, a surgeon from North Shore and the Brain Cancer Group, Marina Kastelan, who's a nurse practitioner, who's also going to be talking to us in the afternoon session, and she's also very involved with the Brain Cancer Group, and Hao-Wen Sim, the medical oncologist, who's both at Kinghorn and at Lifehouse, as well as very important to COGNO. So one of the slips here pointed out that this has been a lot about glioma and asked some questions about some other tumours, which we will deal with. So I guess it's been a very specific decision this year to keep it to the most common primary brain tumour, which in adults is glioma. But I know Jonathon also covered other tumours in his talk, but yes, it has been quite a bit glioma-centric, but the Brain Tumour Alliance Australia does provide information and support for other primary brain tumours. This group and forum is not generally focused on brain metastases, because that relates to tumours that have come from other parts of the bodies, but there's other support groups that relate to the support of patients with brain metastases. But Brain Tumour Alliance Australia can certainly also help point anyone that needs help with that in the right direction. So, if there's any additional questions, we'll be able to address them. And I think, Ben, there might be a roving mic that at the end you can, if we kind of collect questions at the end, if any come up based on some of the answers that actually happen here. So we might actually kind of go again chronologically. So we've had a couple of questions, as usual, about causation. So there was a patient who wrote, or someone in the audience who's written, is everyone born with cells that can be cancerous? With the right trigger, for example, radiation, diet, sickness, can that become a cancer tumour? So I'm happy to throw that open to the panel group about, are we all born with cells that can become cancerous? Okay, John's first cab off the rank.
I mean, the short answer to that is yes. Obviously, brain cancers in general are not things that generally have obvious triggers. So some of the other environmental exposure cancers, the obvious ones are things like lung cancer and smoking, melanoma and the sun, those sorts of things. As gliomas arise from glial cells, which are the supporting cells that surround and nourish the neurons. So they're the cells that divide rapidly, and therefore they're the ones that are at risk of developing into tumours, as opposed to the nerve cells that don't reproduce as much now. So, the short answer to the question is yes. There's anyone has cells that could turn into cancer.
Hao-Wen, you were leaning in?
Yes, I agree with that. I think at the moment, a very small proportion of tumours, we have a specific cause that we can link with that. So it would be less than 5% where there's some kind of strong genetic link, or there's been a prior history of high-dose radiotherapy. Most of the time we think it's fairly random, and that, anybody's at that random risk over their lifespan.
Michael?
Yeah, I think a model to think about it is the radiation-induced malignancies. So we know that from atom bombs and nuclear accidents that radiation can cause cancer. Likewise, in people we treat, we can potentially cause a cancer that's unrelated to the previous cancer. So that time frame is often 10 to 15 years after the exposure of radiotherapy. So you can actually get a tumour emerging from the effects of the radiotherapy given, say, in 2020, the tumour might arise and be evident in 2030, 2035, so 10 to 15 years later. Pleasingly, that's a very low rate in our patients who are long-term survivors. It's about 1 in 2,000 for adults. For young children, it can get down to as low as 1 in 200. So that's why we have a lot of strategies in children to try to avoid that. But the latency time, or the lag time, is about 10 to 15 years.
Thanks. There are quite lots of different theories. Like, some people say that we've got cancer cells floating about all the time, and we've got these kind of range of cells which kind of knock them out. And we've got tumour suppressor genes that keep everything in order. And it's things like smoking which damage cells and damage all those regulatory sort of approaches or perhaps sickness or stress that can allow those cancer cells to sort of take hold. But I don't think we've come up with a definite theory of cancer causation in general, although some cancer causations are really well understood, like I think bowel cancer, step by step we know what happens first, second, third, fourth, and certainly genetically and molecularly I think we're getting a much better idea of which mutations happen first. So, people have mentioned IDH mutation in certain brain tumours, and that's something that happens really early. So we're sort of learning more and more about causation, but yes, in answer to the question, everyone probably is born with cells that can turn cancerous with the right trigger. So another causation question, which I don't think we've ever had a forum that this hasn't come up, is what is the evidence of the use of mobile phones on the incidence of brain tumours? So, John, Michael?
Yeah, I think the evidence is very sketchy. There are some studies to suggest that there's some causative link, but none that are conclusive. The incidence of brain tumours has increased. That's more in keeping with the ageing of the population than any other factor. People have said, maybe it's because more people are using mobile phones, but I don't think that's definitively proven. But I must admit, this isn't a topic I've looked at for a few years, so if anyone knows of any more updated evidence to the contrary, then now's your chance.
Marina, do many patients sort of say to you, did my mobile phone cause this?
If they come from one surgeon, they might, yeah.
Yeah, we do get that question quite regularly. But as Jonathon said, I think over the time that I've been doing my role, I don't think that, with the use of mobile phones and that we've had them now for 20, 25 years, the incidence of primary brain tumours hasn't really increased. And we're seeing more of the older population, the 70 plus age group, 80s, 90s, and some of them have never ever used a mobile phone in their life. So,
and I remember Michael Barton, who I used to work with at Liverpool, used to sort of say, look, if it was really that dangerous, we'd be seeing a lot of ear tumours because, for many years, we'd hold the phone against our ears. And there was sort of a little bit of possibility that maybe the older analogue phones were perhaps a bit more dangerous than some of the new digital ones. And certainly there is emission of radiation from the phones, but I think, as everyone sort of said, there's no hard and fast sort of causation relationship that's been proven.
I think if you consider it to be a radiation-induced cancer, then you're looking at that 10 to 15-year lag time before you start seeing cancers. And we know that we've had mobile phones from, pretty much in the population from the mid-90s. And the earlier ones, as Liz mentioned, had a lot more electromagnetic radiation. And so they would have been potentially much more lethal if you look at radiation-induced abnormalities. So 10 years on from that, we should have seen an outbreak of tumours about 2005 to 2010. We haven't seen that.
John?
And now no one holds them near their ear anymore. But, there's a huge increase in incidence of thumb tendinitis, a thing called tenosynovitis from sending text messages.
Okay, so John, you've got the mic, so we might put you, there's a couple
I made a mistake there, didn't I?
There's a couple of surgical questions, but there's questions that other people can jump in on. So one question was, can location of the tumour change the grade? Does where the tumour is affect things like the grade?
Yeah, not specifically. I mean, the grade is a histological diagnosis based on particular features. There's two ways we think about pathology. So first of all, it's all a bit of pattern recognition, right? So there are some tumours that if they look a certain way, then even though that they look a certain way, then they'll behave a certain way. So and then the other sort of, side of it is the fact that we have particular features within the tumours that suggest there's a large number of dividing cells, and therefore the tumour's growing more rapidly. So the best sort of way to apply that is in meningiomas. There's a whole bunch, something like 17 sort of subtypes of meningiomas, and there's a whole bunch of them that we know behave very indolently. They don't grow very quickly unless they have a certain number of features. But there's a couple of other patterns that we see that we know behave more aggressively even if they don't have those features. So when we talk about the location of the tumour itself doesn't make that much of a difference, but before surgery sometimes it helps us guess what type of tumour it is. Okay, so things that are more sort of based on the cortex are more likely to be an oligodendroglioma, for example, in some instances. So we might tailor the surgery that we do based on the fact that this is possibly something that's going to respond well to radiation and chemo. I guess there's a link, but it's not a box that gets ticked when they're evaluating the grade of a tumour.
Okay. But as Jonathon elegantly said this morning, location might not affect the grade, but it affects what we can do with it. Because if it's in a really important part of the brain, which the surgeons like to call eloquent brain, you have to leave a lot of the tumour behind. And that then sort of dominoes onto, if you've got more of a tumour there, then there's less efficacy of the radiation and the chemotherapy. So, all right, so, and some more surgical questions. Are gliadel wafers offered? And if not, why? So there was a lot of interest in this, about 14 or so years ago. And just before I hand over to Jonathan, gliadel wafers are actually these little wafers with chemotherapy infused into them that the surgeon used to use after they resected. So,
yeah, so I think the story with gliadel wafers relates to the complications associated with it, right? So just like all decision making in life, it's risk and reward, right? So with surgery, with gliadel, fundamentally the decision was there was always going to be some complications, right? With any operation, and with sticking something in the brain like a wafer in around a tumour cavity, there was always going to be some complications. Now, of course, we'd wear those complications if it meant there was an increase in survival and improved outcome. But unfortunately, it seems that the complication rate exceeded the benefit. So they've really just gone out of fashion. Along with that, gliadel, and again, Elizabeth's probably a bit better on the timing of this than me, it was really around the time where chemotherapy regimens were changing. Temozolomide had just kind of come on board. So I think the combination of those two things, the systemic treatment got a bit safer. And yeah, we had this kind of this way of delivering high doses of chemo to that surrounding brain, that infiltrating kind of edge that I was talking about and that Michael was talking about. But so we had this slightly safer chemo and another treatment that was quite risky, so that sort of, it meant that, probably the balance fell in favour of just giving the temozolomide rather than the gliadel.
Yeah, the history is actually quite vexed. So the gliadel wafers, it's a chemotherapy called carmustine or BCNU, which is a really old-fashioned chemotherapy that we used quite a bit last century. And when the papers came out, it was not that long after the Stupp papers came out, and it was a very similar improvement in average survival. And there were a couple of studies looking maybe if you did it sequentially, it would add something, but those pivotal studies weren't actually ever done. The ones where you added the temozolomide with radiation, so the surgery with the gliadel wafers, followed by concurrent chemotherapy radiation, followed by chemotherapy. Those just never really happened. And in Australia, it was sort of a sad, funny story in that the PBS approved gliadel, which is unusual that things get onto the PBS, but if people know the politics of PBS is Medicare federal, so not approved in the public hospitals. So unless you're putting gliadels, into the brain at a corner shop, the public hospitals couldn't use it. The private hospitals could, but the public hospitals couldn't because it was on the PBS, but it wasn't approved in the state hospital formularies. So it was a bit of a sort of debacle. But I think Jonathan's right in that there were sort of side effects and concerns. And I remember a surgeon I was working with at Liverpool, the first patient he used gliadel with, the wound broke open and he had to rush them back to surgery, I think, that night, and never used them again. So you have a bad anecdote that often stays with you, even if the level of proof looks quite good. And I'm just going to use Chairman's prerogative and ask an additional question, not about gliadel, but about glilan. So there's a particular substance that you can give a patient before high-grade glioma surgery which lights it up like fluorescent pink, and there is some evidence that if you do have it lit up in your operating room, there's a more extensive surgery. So just in terms of where glilan is, why do some hospitals use it, some don't? What's the future of glilan?
So this comes back to what I was discussing in my talk about the extent of resection and the difference. Is there a significant survival advantage from doing a 98% resection versus a 99% resection of the contrast-enhancing tissues. So, first of all, Glylan is most, or 5-ALA is most, just in case people don't know what that is, it's a drug that's given at the start of the surgery or slightly before, and then using the operating microscope that we have, you use a particular light with fluorescence so that the tumour cells show up as a different colour. It's kind of, it requires some technology in terms of the microscope. It requires some protocols and things because it makes the patient very sensitive to light, which obviously in a situation where you're in an operating room with bright lights, just like the ones shining in my eyes, then that's kind of a bit of a risk. So first, there's no question that 5-ALA in the studies leads to a greater degree of resection in terms of less abnormal tissue on the MRI. What I'm not entirely on board with is that then necessarily leads to an improved survival, and certainly an improved survival with a decreased rate of complications from surgery. So it might be that going for that last little bit that looks like pink, that looks pink on the down the microscope, that might be the bit that causes the deficit. So I think a lot of surgeons, and myself included, have kind of erred on the side of caution with that in terms of shying away from 5-ALA and not and going off the kind of light microscope. It's a pretty controversial area, though. There are certainly some zealots in the neurosurgery world who think these operations shouldn't be done without the use of 5-ALA.
Yeah, I think our unit still does use it, but it's not funded by the hospital. It's, I think, funded by a foundation or something. So is there any move to get it funded or not?
Yeah, I think there are some hospitals where it's approved, but yeah, funding's another issue. And again, that's the reverse kind of paradox. I think that the patients being operated on in the private hospital have to pay for it, but those in the public do not at our hospital. So, again, it's sort of, it always sits a bit uneasy with me when you have to, you can only offer a treatment to subgroups of patients based on non-clinical things. So again, that's one of the reasons I personally haven't endorsed it, but that's a personal
and
stance.
Talking about avoiding deficits, just a quick additional surgical question. Awake craniotomy. You put up a slide mentioning Ted Kennedy and awake surgery. So how much uptake of awake surgery is it? Does every neurosurgeon do it? Is it some that really believe in it? There's certain tumours that lend itself to awake.
So I guess there's a few things. I think there is a lot of individual preference there. I know there are surgeons who do a lot of gliomas and never do them awake. There are surgeons that will do, up to maybe never more than 10 or 15% of their patients. And in fact, there's studies from North America where they were doing all glioma surgery awake. And part of the motivation for that was because these were done as day surgeries. So again, saying there's no anaesthetic and, out the door, for want of a better way of saying it. Now, I think that it's hard. It's harder for the surgeons. It's obviously a lot harder for the patients in terms of the process and in terms of the the stress of it, and that's okay. So my personal threshold is based on tumours that I think particularly more low grade than high grade tumours, and ones that are in or near eloquent locations. So, and the whole principle behind it is if we do an awake guided surgery, if we start to get first of all, we'll always, again, without getting too bogged down in the detail, most of the high-grade tumours we sort of take out as a ball, as a lump, so we, work around it and then remove the middle of it so that we can kind of roll it in. Whereas with lower grade, with awake surgery, we have to kind of move as a wave from one side to the other. And going to the dangerous part last, as you can appreciate. So you go to the the part that's going to be most likely to cause a deficit last. So there's a lot of subtleties about it that mean that it's sort of something that not many people will do regularly. So of the sort of 5 of us who at Royal North Shore who do glioma surgery, really only 2 of us do it regularly, myself and one other. So, you know, it's not something that we that was done too regularly.
And Marina, would you have any comments about how you counsel a patient about being awake for surgery?
I have to say I'm not at that end of the discussion. That's really a surgical thing.
Yeah, I think around that, the size of the tumour and therefore the duration of the operation is a big factor, right? Because, you know, you can appreciate that it's uncomfortable, and having someone in that sort of a position for 2 or 3 hours, and, you know, anything more than that, you know, people don't tolerate it, and again, that's part of our decision making.
Yeah. I will say that certain people, you know, it is about counselling and talking with them, and about what is it as a person they're going to be able to do, because having an awake crony for some people is just not the right thing.
So, John, you operate till there's an obvious deficit, then you stop. So,
we operate till we either think we've got the whole tumour out, or until there's a deficit, and then we stop, and it almost always recovers.
Yeah. I'm just going to jump off for some non-glioma questions. So let's quickly talk about, there's a couple of quick questions about meningioma. So when is 3D imaging of tumours used, and could bone invasion from meningioma, how important are the bone changes if the tumour is not growing but the bone lump is? So do you want to talk a little bit about invasive meningiomas?
Yeah, so with meningiomas, there's like glioma, there's a sort of, I guess, grading systems based upon, and again, what that is looking at a microscope and seeing features, down a microscope, and seeing features that suggest that this is going to grow more rapidly. Brain invasion is something that suggests that the tumour is going to grow more rapidly. Bone invasion, not so much, but it may alter our surgery. We see sort of 2 things. We see the situation where there is tumour in the bone, but we also see what's called hyperostosis, which is a reaction in the bone. So whatever it is that some of the hormones and things that relate to the tumour and the tumour growing lead the bone to become thickened. And generally what we do in that circumstance is just, you know, remove that overgrown part of the bone with a drill before we put a bone flap back. The other part of the question
was about 3D imaging.
Yeah. Again, I mean, I guess part of the art of what I do and what Michael do in particular, because we're, you know, of the localised nature of the treatments, is, you know, we get used to thinking in 3 dimensions, even though we're mostly looking at the pictures you saw were pretty much all 2D. So it's just, I mean, like, the pictures are nice in sort of helping us kind of visualise things, but most of what we do is based on 2-dimensional imaging, but viewed in 3 planes and being turned into 3 dimensions in our brains.
And Michael, proton beam use in meningioma, skull-based proton treatment.
Yeah, as I mentioned, there may be benefits for protons in reducing the dose to the surrounding brain away from where the tumour is. We sort of replicate a lot of that now with better treatment design. And if you look at the studies with protons, and we compare the average brain dose in the proton studies compared to what we're actually delivering in our own treatments, our average brain doses are lower than the protons. And that's because we're mapping out the tumour better, and we're actually not expanding our radiotherapy fields into that normal brain as much. However, there's a lot of biological benefits for it, and we're going to have that, a lot of physical benefits for it, and we're going to have that machine in Adelaide in late 2022. There's a bit of a concern with if you're treating a patient with meningioma, the main role for a bulky mass is still to do a surgical debulking. We need to get the pressure out if there's pressure symptoms. If I treat a meningioma, say in the base of skull, that's not accessible for surgical resection, then I'll give that treatment, and it'll take 3 years before you're getting any significant reduction in the volume of the tumour. It's a big lag. So if someone's got symptoms, it's better to reduce the volume of the tumour with surgery and then come in with radiotherapy afterwards. So coming in with protons is not going to replace surgery. It's potentially going to get the dose down lower to the adjacent normal brain. But with everything in medicine and life, there's a cost. So if you're putting protons into a tumour which is very superficial here, and you're sparing that amount there, you're going to put a lot of higher dose on the skin surface here. So you may end up with unusual patterns of hair loss, etc. Whereas in modern treatments with our radiotherapy now, we're actually getting lower doses on the scalp, and we're getting return of hair afterwards. And it may seem like a minor aspect, but it does become a very important aspect for people who are long-term survivors. Obviously, protecting the normal brain is really important as well if you're a long-term survivor. But we're actually getting more understanding about what are the impacts of the very low dose, which is going the other side of the brain, and it doesn't appear to be as significant as what was concerned with those studies done back in the 1990s.
Great. All right, another non-sort of mainstream glioma question. So specific question about a type of brainstem tumour that we often see more often in our younger patients. So just a broad question about treatment advances in DIPG, which stands for diffuse intrinsic pontine glioma, which is in the brainstem, so grade 2 diffuse astrocytoma. So perhaps if we throw back to John in terms of what's the sort of standard approach, and Michael will have something to say about this too.
Yeah, this is not an area I have a huge amount of experience with because it is mostly a paediatric and adolescent, type tumour. But generally, my understanding is most of these tumours get some sort of at least biopsy for histological subtyping. Sometimes it's hard to tell because you have the sort of polar extremes of a polycytic astrocytoma, which I mentioned in my talk as something that's resectable and often curable with surgery, or it's a grade kind of 4 tumour that's highly aggressive, and sometimes with the radiology we can't tell the difference. So again, that the principle of maximal safe resection holds, and that may often end up being just a biopsy in tumours of this location, and then most of them the treatment is over to radiation and chemo.
Yeah, so it's a lower grade, but it's in a tricky place. So there's a question here which will fold into your answer here, which is what are the long-term effects of brainstem radiation?
Yeah, so the issue with tumours which are predominantly in that midline area down in the brainstem is that we're limited in the dose of radiation we can give. So up here in the top part of the brain, we're treating patients with, as a standard regimen, for say 60 units of radiotherapy over that 6-week period. And I'm re-irradiating patients who are going well above 100 units. So we can hit those areas of the brain, obviously take care, but we're fairly comfortable around that dose of 60 units, and we can probably push it a bit higher in future studies. In the brainstem, we start to get big neural injury when we're going above 55 units. Now, then, with modern technology, we can target exactly where the tumour is and give a higher dose right to the tumour and limit the dose to the normal brainstem and just hope there's no interweaving fibres which go through there. But you are limited in the safe doses you give in patients who have got brainstem tumours, because it's not so much the long-term effects, it's actually the short-term effects, is that you actually get a big swollen necrotic lump with a whole lot of dead cells in the brainstem, and there's no room to move. So John hasn't been able to open up that area and create space, and when you get the inflammatory change, you can actually, by pressure, extend into other areas of the brainstem, and so you might get other deficits arising. There's certain drugs which might help to reduce that. Steroids, not so much, because they're only a very temporary measure. But you're very much limited to the doses you can give. And as a result, that's not very good anti-cancer doses. So we're limited. So for things like DIPG, we really want to find a molecular marker and a target. And so we pass it down that line.
So I think in Australia we're lucky that we do have paediatric neuro-oncologists who have particular expertise and interest in DIPG. Quite a proportion of these tumours do have specific histone modifications, We don't have sort of proven drugs that target this at the moment, but there are there's a whole wealth of sort of exploratory drug exploration looking to find effective drugs. Over at Sydney Children's, Professor David Siegler is doing a lot of work in this area. And there seems to be some potential here. So I think that's probably where we're going. If a tumour can't be accessed with local regional treatment, maybe we'll find targets that we can exploit with drug-based therapies.
Jonathon, you had a sort of passing comment about, most of these do get biopsied. I remember when I started sort of managing brain tumours, like at the turn of the century, there were quite a few tumours we just made radiological diagnoses and left alone. Are there any tumours now that surgeons are happy to kind of make a provisional diagnosis and not go in and biopsy? When would you not go in and biopsy these days? What kind of tumours or situations?
So again, my role is to provide tissue to the molecular biologists and to tell Michael and Hao-Wen what to do, right? I think that obviously there are. I've had a number of patients, generally elderly patients, maybe people with a high level of disability related to their tumour or other medical comorbidities that make me concerned about surgery. And we've had instances where I've then spoken to Michael or the oncologists that I work with and said, will you treat this person without a biopsy? And usually the answer is no, but it is, it is something that we talk about. And again, I think the other thing too is another situation, for example, was patients who have seizures from low-grade gliomas. So, young patients with tumours that don't enhance with contrast on their MRI, and obviously now we have PET scans and things to help us kind of guess the grade. When I started in neurosurgery just over 20 years ago, we would often, there would be patients that we'd just manage their seizures and watch their tumours, but more and more we're starting to operate on those patients earlier because we do think there is some alteration in long-term prognosis with early resection there. Michael, maybe you want to comment on people you would treat without biopsy?
We're now going into a phase of trying to work out tumours based upon MRIs and do that spectroscopy, so try to get a molecular diagnosis based on a non-invasive measure. We're not there yet, so in most situations we need a biopsy, but we do treat people with lesions in the brainstem where we've had long discussion, multidisciplinary discussion, multiple opinions, and we say, look, the likelihood it's going to be tumour X, we're not 100% sure, and then we counsel the patients as to what the risks of the biopsy are and what are the uncertainties of treatment without a diagnosis, without a tissue diagnosis.
Okay. John, then Hao-Wen?
Yeah, just one more thing to say is what are the other things that, so occasionally infection or demyelination, MS, is they're the two other big things that we call differential diagnoses.
Multiple sclerosis.
They're the other things that obviously radiation or chemo in that context is bad. So there's sometimes other tests, like for example in multiple sclerosis, sometimes there's lumbar markers in the CSF, so a lumbar puncture might be helpful. There's all sorts of kind of other things, but generally we need something relatively definitive.
Hao-Wen?
Yeah, just going to say, in terms of drug-based therapies, in general, they greatly prefer to have that biopsy information. Partly we want to exclude that we're not treating something very different, like a lymphoma or infection.
Or tuberculosis,
Yes.
weird things.
And I guess moving forward in terms of the research setting, increasingly we want to get as much information as possible to drive this field forward. So having more tissue, I think will help us develop new therapies, which we desperately need.
Yeah, a patient of mine sort of springs to mind. I've got a young 22-year-old chef who was diagnosed with a tumour in her optic tract when she was a baby, basically, and we ended up just biopsying her last year, and it turned out she had a particular mutation, something called a BRAF, and she's now on these combination of drugs, and the tumour has sort of shrunk 40%. And she'd gone all these years without. We wouldn't have had the drugs 10, 15 years ago, but it's really an exploding field, and so there needs to be a really good reason not to get tissue now. Michael?
And we're also, in patients with metastatic disease, we're asking the surgeons, say if you have a patient with lung cancer and they've had significant treatments based upon a diagnosis we know about, we've got molecular diagnoses, then there's new lesions appearing. We actually ask the surgeons often to go in and take out one of the metastases so as we can get a new tissue diagnosis to see if any of the molecular markers have changed. And we're seeing that craniotomies now can be performed in sort of non-eloquent areas quite readily and easily. I mean, it's easy.
Patients sometimes go home, the next day? Sometimes they don't they, John?
I always say it's easy for me to say, but John's in there and all the rest. And the patient's going through the experience. But it actually has now become a therapy or a diagnostic tool that we're using much more frequently. And a craniotomy to take out one of 10 or 15 brain metastases is going to provide no clinical immediate benefit to the patient, but may be able to guide the medical oncologist to deliver a different form of treatment.
And it's happening with other cancers too. With my other head, I do prostate, and often, if the PSA, which is a blood test, is in the thousands, you go, well, we know the diagnosis, no point to get tissue, but now you have to get tissue because there's all these classes of drugs that are relevant if you've got certain things that are overexpressed. One last non-gloma question for you, Michael. Is radiation therapy used for primary B-cell lymphoma of the brain?
There was concern in previous years about delivering radiotherapy for primary B-cell lymphoma of the brain. Now, the trouble is that a primary CNS lymphoma is a diffuse lesion going through the whole brain. So the treatment has to be directed to the whole brain. And in patients who are long-term survivors, there was potential neurocognitive deficits which were happening in the sort of 18 months to 2 years after treatment. The condition itself can lead to that same neurocognitive disturbance anyway, but the radiation treatments seem to add more on it. So as with brain metastases, we now adopt a policy of whole brain radiotherapy avoidance, if we can, for primary CNS lymphoma, and there's a whole lot of drugs and targeted therapies which have improved outcome. However, some of the drugs require a very high dose of intravenous chemotherapy, which is quite toxic within itself. So there's a group of patients who we're now returning back to giving some radiation treatment to. And also we're treating patients at time of relapse because we can induce another remission. So the upfront answer is no, we avoid it, but we are now treating more people at relapse because we do get a good response with lymphoma, which is a particularly sensitive type of cell, and we trade the balance of potential neurocognitive deficits versus the longevity of survival.
And what does the surgeon do how do you know going in that it's more likely to be lymphoma and not to do an aggressive resection, John?
I guess there are some imaging features to suggest that, so that's, and location, but again, we honestly never really know. So yeah, it's a tricky one.
Okay. All right, so some more questions on radiation, Michael. So you're on the hot seat still. So you talked about how we're now, you've gone from the box and the protractor circle to something much more elegant. So one of the questions is, with changes in radiation to make it more targeted, have we seen an increase in life expectancy, or is it just less side effects?
If we look at the results from for glioblastoma, if we look at the results from the STOOP study, or the EOHC NCRC study, which was presented and published in 2005, they had a median survival there, which we now deem to be very poor. We can actually improve significantly upon that. And what has changed is nothing in the recipe. So the recipe is exactly the same. It's radiotherapy, 60 gray after surgery, and temozolomide. The same drugs, same radiation dose. But the median survivals and the quality of survival has significantly improved. And we've seen an improvement over time. And we think that is partly to do to better supportive care of patients through the course of treatment and in follow-up. And also because we're now performing better imaging and we're now seeing areas of tumour that we didn't see before. And we're now targeting those. And I think there is a survival benefit which is hard to quantify because there's no randomised trial between the two techniques. But if we look at what's happened over time, the way we look at imaging is completely different. And so our way of targeting things are completely different because we couldn't target it very well back then, but now we can. So the survival, I think there is a survival benefit. We are seeing that in patients with RDH mutated tumours as well, where there were projected 10 to 15 year survivals, which are now much higher rates compared to what were historical. So above the morbidity of treatment being improved, I think we're also seeing survival benefits.
Okay, great.
Any questions on the same topic?
Ben, do you want to just maybe is there a roving mic, or we can just lend? Yeah.
Oh, I'm happy to yell.
I know that we're filming it, so we should get it on the microphone.
It's sort of interesting, what you're saying, life expectancy and all of that is based on previous data. We've got 15 years of results, 10 years of results, or whatever, and we're basing our perceptions of what we read in literature on that data. But what you're saying is that you're very positive that you're getting an increase in that, but we're not seeing that in any literature. Why isn't there even short time-based indications of how you're performing or expectations of how it's travelling in future? Why aren't we going the other way rather than just basing it all on built-up data?
Yeah, I guess what reaches publications are more major trials, but we report our outcomes. I analyse my outcomes every year. In our department, we've got very much an outcomes-based assessment, so each year we update our survival figures of patients treated over time, and then our last publication on, say, glioblastoma for median survival outcomes was about 2017. Because they're not randomised control studies, they don't reach major publications, but they're still, I mean, our last glioblastoma publication was the Australian New Zealand Journal of Surgery. I put it into that journal because we wanted to show that there was a paradigmal shift in survival, because we were seeing surgeons, not neurosurgeons, other surgeons and general practitioners and general physicians being quite negative and pessimistic about our patients who are going to see them for things like rehabilitation or for other health problems. They were being looked at and say, oh, you've got a patient with a glioblastoma. You have had a history of a glioblastoma. Well, we'll just do, may not treat you as thoroughly. We are now telling those referring practitioners that there is an excellent chance of this patient being alive at 18 months to 2 years, and there's a cohort of patients who are now at survivals at 5 years. And we're finding more molecular features which are selecting out those patients which produce that outcome. Those are being published, they're out there. And Cancer Institute New South Wales is now on a drive to reproduce similar to what we're doing with our own data and our outcomes research, in that they're trying to get the various centres to produce their data for date of diagnosis and survival dates and benchmark across New South Wales. It's always hard though, because there are people present with very individualised problems, so sometimes you're measuring apples against oranges. It's a bit like the My School Report websites. So there will be some schools performing really well, but they're in disadvantaged areas, etc. But the data's there, and I would say that for most oncologists that you should, when you're seeing a patient, you should be asking the oncologist, what are your outcomes like? And that's the approach that we've adopted. And there's also a factor called provider volume. So from other areas in medicine, in oncology, provider volume, how many patients you treat, also influences your outcome measures. We're currently looking at our data at the moment in terms of carer mastery. So how good or how effective we can educate the support person and that if that support person can have confidence to assist with the management of their loved one, then that might have an impact on outcome as well.
And we've looked at people like having staff like Marina. Like Marina's a gem. Having a neuro-oncology care coordinator, nurse practitioner makes a huge difference, particularly for isolated patients who don't have a network of carers, just in terms of that that support. But I think as Michael said, there are articles. There was, I think, a New South Wales Neuro-Oncology group and I think some other interstate people who looked at some survival at 3 different time points in before temozolomide became available, after it became available, and more recently. And it's not home runs, but there's definite improvement in survival. And I think the other thing that's really different is there's much less nihilism or negativity about treating older patients. I think with older patients sometimes didn't even get biopsies sort of 20 years ago, but now I think we want to make sure we're not missing sort of lymphomas or other things in older patients, and some older patients do really well. So you.
We still get called by an orthopaedic surgeon who was doing a hip replacement on one of our patients, and he asked me, should I put the prosthesis that lasts 10 years or the one that might go for 20 years? And that prompted us to publish our outcomes, because we don't publish them in neuro-oncology journals because we're preaching to the converted. You publish them in Medical Journal of Australia and other places where are going to have a greater community awareness.
When you were reaching for the microphones.
Just to mirror that, we are seeing with the contemporary sort of large randomised trials that the comparator historical arm, it's definitely an improvement in what we're getting. So with the Stewart paper, 12 to 14 month improvement, but we're now seeing with the control arm sort of up to 18 months sometimes in the newer trials. This is a major consideration with trial design. We're very cautious with comparing back to historical cohorts, because your treatment might look very good compared to historical cohorts, but actually it might be that creep over time that the standard of care is actually gradually improving. So we're definitely seeing this phenomenon, and we're sort of having to factor that in terms of trial design.
Couple more radiation questions. How long does it take scar tissue to form post-radiation? For example, is there a specific time frame where scars could form and won't form at other time points?
Yeah, there's 2 time frames that we generally talk about. One is the acute response, where you get the inflammation, and that inflammation is what we call pseudoprogression, or the big swollen areas in the brain, and that historically would come up in the sort of 1 to 2 months after radiotherapy, but we're now aware that can come out about 3 to 4 months, and then that inflammation or neuroinflammation may take months to settle down, and that's a really unusual time course. It's very hard to predict. The other major event used to be what we call necrosis, and that would come out 18 months to 2 years after treatment, and that can still occur around that time, and that's from a damage to a blood vessel rather than a swollen area of the brain. The blood vessel damage can then cause a swollen area of the brain, but the initial insult's probably a damaged blood vessel. And as our patients are getting living longer, we're now seeing that event also potentially happening in the years down the track. And in our patients with IDH mutated tumours, around 25% of people will get a little white dot or a little bit of inflammation, which might occur anywhere between 18 months to 8 years or more after their treatment. 2 patients at the moment who are in 10-year follow-up have both got little white dots which have not progressed over 18 months. So these are unusual. They're going to a new era of seeing things. The other type of scar tissue is what we call the cloud or the gliosis. Often that's seen after the surgery, where there's surgical resection, you get these changes, and that emerges in the first 12 months after the insult. And so after 12 months after surgery or 12 months after radiation, we can see that. And that generally turns itself off, and you're just left with that flare or scar change.
Okay, great. And one last question specifically for radiation is, do we only receive radiation? Sorry, John, did you want to, you grab the...
Oh, I was just going to make a comment about one of the challenges and one of the applications of our advanced imaging techniques is distinguishing between these longer term radiation effects and progressive tumour, because again, a lot of it's about symptom management, but also, you know, if we see that the tumour's progressing, then, you know, that might be an indication for more surgery, just so we can get more tissue, and particularly as more and more treatments come online over the next period of time.
Great. So historically we used to say radiation you get once. So this is a question which says, do we only receive radiation for brain tumour once? Is there ever a second round of treatments? And think it is a changing area. So.
Yeah, it definitely is. So I've probably re-irradiated about 150 people in the last 3, 4, 5 years. It's a common practice now for us. We generally use it for patients with glioblastoma as a point of last attack, and we only give those really high doses, which I mentioned before, going up to about 100 units of radiotherapy with Avastin on board, because the Avastin helps to suppress that swelling event that would occur with the radiotherapy. So that's in the patients who have got, unfortunately, short survival duration, and that re-irradiation can trigger a second remission, but often it's not a very long remission. In our data that we've published was around a median survival of 6 to 7 months. In a position where they had refractory disease, the tumour was growing and left untreated, at that point you're probably expecting person's life expectancy to be in the order of 4, 6, 8 weeks. So we do gain some things by re-irradiation, and it appears to be reasonably well tolerated when we're giving it with Avastin, but we don't have a lot of people who are alive in glioblastoma 2 years after re-irradiation, so we're not sure what the impact of giving those very high doses is. The other group of patients we're re-irradiating is the patients with IDH-mutated tumours who may have had radiotherapy in the past, and then we come back in again with treatment some 10 years or so later, and those patients we've got to take a lot more carefully. We give similar high doses, and we often don't start with Avastin, but we might need to bring Avastin in, and that seems to be promising. We're getting patients who are getting longer remissions with that, going out in 18 months or so in our data that we're seeing. But essentially, we re-irradiate at the moment with the ability to have Avastin or that bevacizumab drug to reduce down the swelling, and we usually leave it as a point of last line of defence.
And when do you tend to give the Avastin? Like 24 hours before, 24 hours after? What's your practice?
For glioblastoma, our patients, I'm normally re-irradiating them when their tumour's growing on Avastin. So when the tumour's growing on Avastin, then that's when I come in with the re-irradiation. For the patients who have got the IDH-mutated tumours, we wait until we're seeing either symptomatic or significant radiological changes, and then we bring it in.
I know that we used to sometimes do a second protocol if the glioblastoma came back on a different side of the brain or an area that hadn't been in the previous radiation field. But more and more, as Michael says, if the patient's done well up front, and it might be 18 months, 2 years, you're more likely to look at re-irradiation than if it's still within the year of the original diagnosis.
And the other factor is that because we're more targeted in our initial treatment we gave, when we come in again, we're actually not overlapping as much as what we would have thought. Not every patient will be suitable for re-irradiation. If there's too much diffuse disease in the brain or the patient's performance status is deteriorating, then we generally will not go down a re-irradiation pathway.
Ben, why don't you come up, because there's quite a few med-onc questions, so you and Hao-Wen can divvy up some of them. So I think this isn't a question. Someone's written, I think it must have been your talk, specialist very young. So Hao-Wen might be baby-faced, but yes, he's
Was that me or Hao-Wen?
So look, this is, I guess, a theoretical question. So, we saw those elegant slides on, I think, quite a few of the talks about how, however aggressive that original surgery is, there'll be sort of cells outside it. And you can understand why surgery can't address it. I mean, I think in the 50s, they were still doing hemispherectomies. They'd take out half the brain and it would still come back. But why does chemotherapy not work with these diffuse cells? So after a round of chemotherapy cycles, why is the brain tumour still there?
I mean, in theory, the idea of giving drugs that can get through the brain, that's the right principle. I don't think we have drugs that are as effective as we want them to be. So we have a limited selection. Only certain drugs can get into the tumours in high enough concentration to cause the damage we want. So when you have, at the moment, temozolomide, the lomustine, bevacizumab are some of the key drugs. We need more active drugs to use. I think that's why the tumour often becomes resistant quite quickly, and we don't get that durable benefit. I think if we had more options, we'd be able to achieve a better outcome.
So there's a question about timeline. Why are we so addicted to this particular sequence of surgery, radiation and chemotherapy? Any thoughts on this sequencing?
I I think that's a great question. I think it's a historic thing. The pivotal trials that were done did it in this sequence. I think historically surgery and radiotherapy have been the mainstay, and sort of chemotherapy came on a little bit after that. But there is interest in looking at variations of this strategy. For example, people have tried giving a bit of immunotherapy just before surgery, for example. Maybe that's a setting where you're more likely to be able to prime the immune response before you've done all these big operations, etc. So people are starting to look at variations of this general schema, but at the moment, this is the standard recipe.
Okay, John?
Yeah, I might speak to that a little bit. There's other cancers and things where this so-called neoadjuvant treatment, which is what Hao-Wen was saying, a bit of chemo or immunotherapy or drug treatment before surgery. Now, let me just kind of, I guess, again, I'm not 100% on the details of the other cancers, but I think things like breast cancer are where that might be appropriate. Now, those things, there might be a biopsy, right? Like an ultrasound-guided needle biopsy, says this is cancer, have some chemo or something, then have a big operation to remove the cancer. So in brain tumours, we're obviously not it's much more difficult to get a biopsy, right? And the incremental risk from doing a biopsy, like that scan I showed in my talk and said how we're worried about bleeding if we do subtotal resections and things, the incremental risk, if you like, from doing a biopsy to a resection, it's not that much more dangerous because we still have to do general anaesthetic, burr holes, passing things through the brain, all those sorts of things. So I think that's something that's always going to be tricky. Plus the diagnostic uncertainty, right? So obviously tissue is the way we get the definitive diagnosis. If we had a scan that would say this is 100% a glioblastoma or this is 100% not, then we'd be in a different position with that sort of thing, right? We'd be able to push that a bit further. And, when I go into almost all of my glioma operations, I'm 95% sure or 98% sure or 99% sure, but those odds aren't good enough for this sort of tumour, to give these treatments, to expose people to these treatments, you need to be 100% sure. So that's kind of, I guess, one of the limitations of the kind of sequencing, if you will.
And a similar sort of, in the same sort of ballpark, is it common to avoid surgery and just do chemotherapy? And you've just explained why it's so important to do the surgery. But,
I mean, to me, my concern is that the chemotherapy is not effective enough to necessarily bypass that initial debulking and radiotherapy effect. And so I think in a lot of cases, I'd prefer that if there's a mass lesion there, that we could try to address the majority of that with local regional therapies.
Yeah, we've just audited our presentation of patients, and patients are sick when they come in with a glioblastoma. So I think it was 48% of patients presented via emergency departments. So if you've got a breast cancer, you don't go via an emergency department. And I think 35% of patients had significant personality changes that were caused by the mass effect as part of their initial presentation. And other patients had, significant motor, 25% significant motor weakness, etc., or speech and visual disturbance. And if you want to relieve those symptoms, radiotherapy and chemotherapy are not going to do that.
So I think surgery, without a doubt, you get it out as much as you can safely. I think the only area where there's a bit of a question with the high-grade gliomas as to whether you might do radiation or chemotherapy, and maybe the frailer, older patients, there's a little bit of evidence that if you're going to just do one, that if you've got MGMT methylation, doing chemotherapy alone might be a reasonable way to go, but if you're not methylated, so if you don't have damage to or silencing of that repair enzyme, better to just do the radiation. So that's about the only scenario I think these days where the med-oncs sort of may go one or the other.
Agree. I think in that setting, MGMT can be a good guide. I think it's different from other cancer types. So perhaps in a cancer like melanoma, where we do have a range of fairly effective drug-based therapies, the threshold to just give systemic therapy might be slightly lower.
I might just jump quickly to supportive care before we go back to some of more chemotherapy questions. So someone's written, although it's still illegal, my husband's benefited from having cannabis oil as part of his treatment and recovery. In New South Wales, 5-year-olds with severe epilepsy are able to access medical marijuana. Does anyone on the panel have an opinion on this form of treatment that is proving effective? So it's not completely illegal. There are cannabis clinics that quite a few hospitals do run now. But Marina, why don't you have a comment about how many of your patients are on or asking you, I'm sure, saying, how do I get it?
So, it is a big question, more so in the last sort of 12 months, I'd say. There are a lot of clinics open that you can access, cannabis legally. And I think patients do get benefit. I don't think there's any flat data, and the doctors will be able to answer this about it controlling tumour as such, but anecdotally, I think with some of the patients that I've seen that have got anxieties or trouble sleeping, the drug's actually been quite beneficial for them to have at night.
I don't know if anyone else on the panel wants to talk about their patient experiences of cannabis and where they think it might have a role.
I think I'll just comment that at the moment, although there are sort of theoretical underpinnings as to why medicinal cannabis may have some benefit against the tumour, we don't have that robust data at the moment, which is why it wouldn't be our recommendation for actually treating the tumour itself. There may be reasons why, from a symptomatic point of view, there might be other benefits, and I think that would be the reason to explore it.
Yeah, I think as Marina said, some people seem to benefit from appetite, some people benefit from anxiety or sleep, but there's certainly no anti-glioma high-level data yet.
Can I just ask, is that with the THC or the THC removed?
I think it's with the...
Yes, so people are looking at various formulations across and trying to find which is... So that's sort of an active area of research, trying to find the optimal formulation.
I think this is like this. Hao-Wen mentioned his talk about study design and the way that we've, and again, it speaks a bit to your question about time lag with research. So that's one of the things that we're all involved in, is trying to think of adaptive ways of altering the way that we do trials to try and answer these questions without having to kind of, go back to the drawing board in terms of a whole treatment regimen, one extra added thing. I think because of the kind of stigma around around cannabis and as a recreational drug, it will always be really difficult to do those studies just because of inherent societal prejudices, I think. But again, it's one of those things that's obviously on all of our plates. We all get asked about it.
I guess we've all been trained in evidence-based medicine, but there's still this very valid question here about why is little consideration given to off-form, maybe they mean off-label medications as an addition to standard of care. So does anyone else? Ben?
Actually, I might just add to Jonathan's comment about study at the NHMRC Clinical Trials Centre. There is actually currently a ongoing cannabis study using CBD oil, and this is not specifically for brain tumours, but looking at using CBD oil in controlling nausea and vomiting relating to chemotherapy. So these things are certainly being studied, but some of the inherent challenges in designing these studies, which may not be apparent at first, are the reasons why they don't sort of perhaps advance. So just as an example, the study that's being performed at the moment, they didn't realise this till they started up. There was actually quite a significant dent in their uptake because people taking these medications weren't allowed to drive. So obviously in brain tumours that's probably a different case, but just to say that there are things being studied out there. Sorry, Liz, you had sort of jumped in, but what was the second part of that question?
Off-label medications, so why isn't there more? Why aren't we sort of more open to using, why isn't there enough consideration given to off-label medications as an addition to standard of care?
Do you want to jump in? Yeah, probably just make a small comment there. I suppose the primary consideration with many off-label medications is the same issue that we may have with cannabis in that some of the preparations and formulations are non-standard, and so it's in some instances some of these things have been studied in a limited setting, but that is one of the sort of considerations when we're designing trials. Perhaps Hao-Wen has something to add there.
And I think from a personal viewpoint, if there is a compelling case biologically for why treatment might be very effective, it'd be preferred if we could develop that as part of a robust clinical trial to develop that evidence base. I think rather than giving these off-label drugs one to one person and one to another, if we could do that in a systematic way, we could actually move the whole field forward. So my preference would be to try to do it as part of these systematic trials.
So a few more chemotherapy questions. So Hao-Wen had to summarise, topics we could spend a few days talking about into sort of 20 minutes, and he did an amazing job. But one person in the audience wanted to know, why wasn't PCV mentioned? So PCV is an old combination, so that's P for procarbazine, C for CCNU, also known as lomustine, and V for vincristine. So Hao-Wen, do you want to have a quick word about PCV?
That's a great question. In a previous iteration of this presentation, I did cover PCV. I just sort of removed it for brevity. I suppose in glioblastoma, we probably give PCV slightly less, albeit the drugs that make up PCV, they can be active drugs. So the lomustine we already use. Procarbazine can be useful in the setting where we have nothing else to use. Vincristine has been used a lot in the lower grade gliomas in the past, for example. PCV is a regimen that's used in grade 2 or 3 gliomas. Most of the evidence base has actually been built on PCV, albeit many centres sometimes substitute that with temozolomide because we think the side effect profile of temozolomide is more straightforward. But it's definitely a consideration. And for example, either you might give PCV up front or you might use it as salvage. I think for the lower grade gliomas, it's something that we would definitely have up our sleeve.
Yeah, I guess, confession, I'm a PCV user. Essentially, as Hao-Wen said, a lot of the evidence in both low grade, so grade 2, and in the oligodendroglioma setting are using PCV at the end of the 1990s. Those studies started, and because the patients lived so long, it took a while for them to read out. And they did extraordinarily well, and there's a particular genetic mutation which has been mentioned earlier today, 1p19q co-deletion. And if you've got that and you get radiation followed by PCV, the studies show that your survival almost doubles, like from 7.8 years to 13.9 years or something like that. So not just a couple of months, which medical oncologists can get excited about, years. So in actual fact, some of us who are sort of evidence-based purists feel a bit nervous about moving on to Temodal, and there's a guy called Andy Lassman who did in oligodendroglioma a retrospective study of 1,000 patients, and the Temodal didn't look quite as good as the PCV. So there's actually a study that COGNO's trying valiantly to bring to Australia, which is looking at STUP protocol with temozolomide versus PCV for newly diagnosed grade 2 and grade 3 oligodendroglioma. So it's still because the best evidence we have in those settings is PCV, a few of us do use it. It is a little bit trickier. It's a strange, weird 6-week thing with a mixture of injections and tablets and dietary restrictions, but it's not that scary. And I think it is easier to go PCV to Temodal than the other direction. So there's a few of us that still are believers. So.
It just freaked me out a bit when you didn't mention it. I was like, oh crap, well, I just had that 6 months ago.
No, there's very high level evidence for it.
It was focusing more on the glioblastoma specifically, but yes, that's definitely part of our arsenal.
And just a quick question for both Michael and the med-oncs. What are the longer term side effects of radiation plus PCV chemotherapy? Does your memory and intelligence drop over time?
I'm not sure about the additive effects of PCV. We have got studies to show quality of life was better with temozolomide than PCV. So I'm not a supporter of PCV. And we're fairly comfortable with temozolomide and its general predictability of outcomes. I think in terms of long-term effects, the lethargy from the temozolomide is there, but that does go away with time. So I would presume the same thing would happen with PCV. The long-term effects are probably going to be more related to the extent of your surgery, the number of craniotomies you've had, and the volume of radiation that you've had to have, and on which part of the brain.
Yeah, there's more issues with low blood counts. Abnormal liver function tests can be a bit scary with the PCV, and very scary but very rare would be effects on your bone marrow. So an increased risk of leukemia, very, very small, but it is probably higher with PCV than with Temodal. But yes, look, it is still used, and I think there is this international study called CODEL looking at whether PCV whether Temodal can safely replace PCV. So as we started 10 minutes late, I think it's important for everyone to have their questions answered. So I'm just going to push on with some more questions, which are research questions. In the US, they're running trials on adding mebendazole, which is sort of an anti-parasitic medication, to the standard of care with temozolomide chemotherapy. Is anyone looking at that in Australia? Mebendazole is, the active drug in combantrin worm tablets. So it might be simplest. We actually did look at bringing that exact study to Australia. The guy who's doing it in the US asked COGNO whether we should do it, and it didn't pass muster at our scientific advisory committee at the time. Particularly the scientists on our committee just didn't feel that there was enough really plausible preclinical data to sort of move ahead with it. And I haven't heard any significant updates about it. Have either of you? No.
So I'm not aware of any sort of active trials in Australia looking at this, albeit this concept of drug repurposing, trying to use drugs that we have accessible, that have low toxicity profiles, and adding that onto treatment. That is something that I know a number of groups internationally are looking at, but haven't seen convincing positive results at this stage, but happy to be informed by them.
Yeah, looking at some older antipsychotic drugs as well. Is it a question? Do you want to just run out?
Just while the microphone,
wait for the mic.
While the microphone goes out, I just want to make a comment that COGNO, whilst we have is a trials group for Australia, there's also a subcommittee looking specifically at the ability to bring trials that are being conducted overseas to Australia. So it's got a large Cancer Australia grant. I'm on the steering committee of that, as well as a few others from around the country. So I think it's always one of those things we wonder if we're a bit isolated, and obviously geographically we are, and we're obviously feeling that now more than ever. But just so just to reassure everyone here that that's a specific thing that the powers that be are looking at.
Yeah. All right. So just quite a few questions about vaccines.
I just want to raise a point about off-label medications. There has been quite a bit of work being done overseas with this at University of Ulm. That's one place I've had contact with. But also there was a study done at Wesley in Brisbane on off-label medications. There's also a group called Care-Oncology the four main medications are a statin, doxycycline, mebendazole and metformin. They work with the treating team as well. They're based in London and the US. But I think, when we always look at following chemotherapy and the standard care, which we do, but when you've got an average survival time of 14 months, you want to look outside the box a little bit more. And, I think it's important also for patients to have some sort of agency in their care as well. We've looked at cannabis and THC as well, and you can get that here. And yes, there's been more interest in this area. Personalised care based on genomics. This happens in the US. Along with polio vaccine work and dendritic cell therapy, people go to Germany for this. A question I have is, when are we going to have these treatments here? We hear about research, the game changers, it's all happening in the lab. When is this going to actually happen? And also when we look at genomics, we invested quite a bit to have genomics done on my family member. and he has EGFR amplification. Tagrisso is used with this in lung cancer. It is free or reduced cost, but with GBM, it is a lot of money if they want to take Tagrisso.
A different part of the receptor, so the EGFR drugs that are used in lung cancer actually don't work in glioblastoma, unfortunately.
Tagrisso is used in lung cancer, but apparently it may help on this, but it will cost a lot of money. And so I'm just raising the point.
Sure.
If personalised care comes in and drugs are applicable in another cancer, and if they're used in GBM, they'll cost a lot of money. There needs to be advocacy.
No, and there certainly is advocacy, and we certainly appreciate where you're coming from, and not only do patients want agency and opportunities, you know, we as clinicians want to offer our patients everything that's possible, but I guess we also do, we've learnt the hard way of not to jump on every bandwagon as well, just in terms of, you know, poor outcomes. So, and just, I guess, just to remind the audience about the arc of trials. So phase 0, which is often what you hear about in the newspapers, which can be really stressful because it hasn't even got into, you know, animals. That's preclinical, you know, often in the lab. Phase 1 is when you give tiny doses, and it's just to see safety and the ideal dose, and that's just like 20, 40, 60 patients. And then when it looks interesting, you go, oh, well, that worked. And that's all comers. That's not just a specific tumour. They go, oh, the kidney cancer patients did well, or the brain tumour patients did well. Then it goes to phase 2, which is, does it work in the disease of interest? And then phase 2 might be more patients. And then it goes to phase 3, which is your hundreds of patients, and in other cancers it might even be thousands of patients. And it's not until phase 3 that the government, if it's a positive phase 3 study, then there's still sometimes years of campaigning before we get it on the PBS. But we do certainly try, as Jonathon says, that's why we're trying to get the more interesting studies across in Australia, so at least we're at the front line of getting access to some of those drugs. And I might just move back to the questions because the questions actually relate to exactly what you brought up. So I might just merge these 3 questions together because they're all about vaccines, just different vaccines. So is there any work on genetic analysis of the GBM or glioblastoma to create a specific vaccine for an individual in Australia to treat their GBM? There's a lot of research, but when will this translate to active treatment, such as dendritic cell treatment? And when will trials such as polio vaccine ever arrive in Australia? So I'll start with Hao-Wen.
So these are all great questions. I think, you know, I presented the general concept behind things like dendritic cells, vaccines, T-cell technology. And conceptually, they sound quite straightforward, but there's actually a lot of complexity behind these treatments in terms of actually, like, for example, dendritic cell therapies, trying to refine the exact epitopes that you're targeting with the dendritic cells and the exact regimens. And so while there are trials internationally in the early stages looking at this, there's still this ongoing process where they're trying to refine this method. And so we're not exactly missing out right at the moment. They're still working on getting that to the right state of technology. So they're all very early stage. I think from a personal viewpoint, I think, you know, collectively in COGNO we have very good international connections. I don't actually think we're missing out on any big therapies at this point. Potentially some of these new treatments like dendritic cell therapies may need a substantial infrastructure. From a personal viewpoint, it would be nice if there was, you know, sort of advocacy for upcoming funding to try to build some of these big infrastructure projects, but I don't think we're missing out right at this time.
Yeah, just to give you an idea, because there was in prostate cancer there was a dendritic sort of cell vaccine that was there was a positive phase 3 study, but it was $120,000 US a month, and it was like an ongoing therapy. So it was so prohibitively expensive that the PBAC and PBS, you know, just can't justify it because it's so much more expensive than the benchmark. And when it's personalised and you've taken your own cells, as Hao-Wen said, it's really, if it's actually involved by taking your own T cells or immune system and changing them and then reinfusing them, that's incredibly labour intensive. There's so much infrastructure involved in a lot of expense.
You set the whole system, and I guess, yeah, I guess, you know, you would need an investment of funding and time to do that. Yeah. And the foresight from investment agencies to give us the money to do that.
John?
I was just going to say that doesn't mean once those things are proven to work, if they are proven to work, they'll be available, right? Like the problem is the trial setting and the funding behind the trial setting. It's difficult, but I think that COGNO tries as hard as it can to, within the funding limitations and within the geographical limitations, to make these things available. So, there are your advocates out there, and it's us, and that's because we sit in this room, all right?
Yeah, we list. Maybe in the interest of time, we might keep moving. One last specific question about a class of drugs. What is the current status and availability of IDH mutation blocker therapy?
That's also a great question. There are active randomised trials being done internationally looking at these drugs. There was one particular trial that we were keen to bring to Australia, but due to funding limitations from the pharma company, they couldn't extend it to us. So we are looking. I think there will be coming up some smaller phase 1 trials looking at IDH blockers. So I think we will see in this space very soon some availability of that. But
and just to remind patients and people in the room, IDH mutation happens in our lower grade gliomas, particularly grade 2, grade 3, and in a small percentage of our grade 4s. Yeah. So, Ben, did you want to say something?
Yeah, just to, I guess, add some general comments to what's been said. The IDH inhibitors are one specific example of something that, I guess not only patients but clinicians find intensely frustrating. You may know that there are some small trials using IDH inhibitors overseas, and in fact, there is actually an Australian company that's manufacturing or using one of those drugs. But one of the areas where I guess COGNO, is keen to, advance advocacy through things like the International Clinical Research Subcommittee is that, the mathematics of living in Australia is we're in a very small population, and so to trial some of these drugs, simply we have to be very judicious about the sorts of trials that we take on. And I think COVID has probably given us a little bit of a taste of some of the dynamics surrounding drug development. No matter which way you cut it, just looking at the sheer number of entities that are developing drugs and the patient numbers overseas, we are always going to have a perception that there are lots of things happening overseas that may feel frustrating for us to not be able to develop. But I certainly echo Hao-Wen's comments in saying that some of these things which do appear promising are things which are still at early phase of drug development. And in Australia at the moment, although sometimes it may not seem so, we do have fairly good access to many of these.
Yeah, I think probably the one thing we don't have access to that some countries do is a very expensive intervention called Novo TTF, which some of you might have seen online, where you shave your head and it almost looks like you're having an EEG, and you wear a backpack, and it's basically flip-flopping the electric fields, which looks as though it's got modest benefit, but it's about $1 million a year. So I don't know, and I think as Ben said, we've got such a small population. The company's not even trying to bring it here. So, but it doesn't. It's not a home run. So at the moment, I don't think many of us are. Do you have any patients that have gone overseas for it?
We have had 2 patients.
Marina, any?
Yeah, we had 2 very early on.
Yeah. So I think in the interests of time and lunch, and the question over there, is it? Okay, great. So look, the last thing, I might just bring it to a close. So this is a longish question. It says, if 20 million people die from brain cancer, would adequate resources be provided towards developing a cure for the disease? Is the level of urgency less because the number of fatalities are relatively few around the world? What can consumers do to raise the level of urgency for more effective treatments? And I think Jonathon's already sort of mentioned quite a bit of that. I think that in actual fact, it's probably the situation is really improved in Australia in the last 20 years. Like when I got back from overseas and a small New South Wales group started in 2001. There was about 8 of us around a dinner table every couple of, and it was sort of like a support group for each other, or as much as anything else, and we'd give talks and stuff. And then the COSA Neuro-Oncology group started. Then COGNO started. Which now it's 900 members now. So it's really impressive. And then there's groups like Brain Tumour Alliance Australia, which has been around for nearly 2 decades. So there is a lot of advocacy. And as John mentioned, there's now big grants, and that's because of people like you in the room and Senate submissions to have special attention for brain tumour patients. And so there's something called the ABCM, the Australian Brain Cancer Mission, and there's grants for that, for research and, as Jonathon said, to bring international studies here. So there is actually a lot of movement. It's frustrating that we still don't have a home run and survival quite as good as some of the other cancers, but it really has changed over these past 2 decades, and I think there is reason for optimism. Does anyone else in the panel want to add to that at all?
Can I just add one small comment? Liz, I know we're about to go to lunch. I think having patients and carers here today is excellent, and we also need to work together with you in some of these aspects. And every time I think of brain cancer, I think of HIV and AIDS research in the 1980s, when a lot of the research was driven by patient advocacy groups, and so organisations like COGNO and some of our scientists, who, if they don't mind me outing them in the audience today, if you want to ask about cell and dendritic cell therapies, and if you're nice to me, I might talk to you about that too, because I've been struggling with that in the laboratory for the last few years. But working together with all these groups is one way forward.
Yeah. And John's a rare species, a surgeon in the lab. So there's a lot of people coming at it from lots of different directions, and there's consumers like yourself who work with the trials group. So we've got an amazing consumer advocacy panel who read through all our study synopses and inform consents to demystify studies for the general population and to help make the studies better right from the get-go. So I think it really is a new era. It's still an incredible journey that none of you in the room want to be on. And what we're trying to do is just make that journey as long and as high quality as possible. I'd like to really thank our panel, so Michael Back, Jonathon Parkinson, Marina Kastelan, Hao-Wen Sim, and Ben Kong, and thank you for all your fantastic questions.
Good afternoon, everyone. Welcome to the afternoon session, and I hope you've thoroughly enjoyed the morning session. Maybe it's not turned on. Is it turned on? I just wasn't talking into it. Just before we start, as you're aware, we have been videoing all of this. We do intend to put it on our website. So for anyone in the room that hasn't gone onto the BTAA website, this is a free ad, by the way, go on and subscribe. If you subscribe, we'll send you out a welcome pack, but if you don't want to get any hard copy, you can just subscribe with an email and you'll get all the information about everything that's happening in Australia. We publicise it all the time. There's an e-news that comes out every month. Later in the year, there'll be the COGNO conference, and depending, we'll be putting up stuff for that if there's more information that you can access. I'd like to introduce Marina, who is also a friend. She's an amazing lady. Patients that are treated at Royal North Shore and both public and private are fortunate enough to have her in their life. And I can see a couple of nods in the audience. Marina's a nurse practitioner, and they're a relatively rare breed. Her specialty is neuro-oncology. She's been a nurse for 30 years. And I think that's why we've got I was a nurse too in another life. Marina's been involved in Neuro-Oncology for about 14 years and has been an integral part of this forum for many, many years. Welcome, Marina.
Well, I'm going to spin this over here. Okay, welcome everyone. Thanks a lot for coming. So as Catherine said, I'm a nurse practitioner. I'm a care coordinator, so I support people who have primary brain tumours. As Catherine said, there weren't many of us around a few years ago. Due to different funding things lately, there's quite a few of us now. I'd say there's about 6 care coordinators in different hospitals. Some hospitals still don't have them. But you know, in my view, any sort of support, whether it's from a social worker, OT, allied health, any sort of thing that's going to help you through the pathway is a benefit than nothing at all. So that's my plug for care coordinators. Today I'm going to talk about, and I have to keep remembering this, of what I'm actually talking about because I do go off on tangents. So I'm going to talk about symptoms to expect with brain cancer. So a presentation with somebody with a lesion in their brain is generally quick, but it can be something that changes over months, and it may be family or relatives or other people around you who actually notice things, and that's more so around the changes in regard to personality, memory changes, the confusion sort of part of it, where the family members are noticing things more than the actual patient is. And changes in gait or limb weakness, that can change over time, where people are sort of just dragging a foot rather than a whole limb becoming paralysed. So things can change slowly, but generally with high-grade brain tumours it tends to be pretty quick, where you present with a sudden onset of headaches or a persisting headache that's just not going away, you know, even with lots of Panadol and Nurofen, as I've seen over the years. Increased drowsiness, so when you've got a lot of pressure in your brain, all you want to do is go to sleep, falling asleep mid-conversation, not getting up. Nausea, vomiting, so when it gets to that sort of crucial point where you've got a lot of pressure within your brain, you're going to vomit and vomit and vomit. Seizures, so sudden presentation with a seizure out of the blue. As I said, any changes to mobility, gait disturbance, limb weakness, changes in balance, speech changes where you're getting the wrong words out, and a lot of the time in your brain you know what you want to say, you just can't get those words out. The personality, memory changes, confusion, I have to say that's probably more so in the lower grade, and you know, not always though, because of the frontal lobes. And any changes in vision, double vision, loss of peripheral vision, I tend to see a lot of the time where people have got none of the top symptoms, but they're going to their eye specialist to go and get a new pair of glasses, and then all of a sudden they're sent into emergency because, you know, potentially they've got a brain tumour. And any new and unresolving urinary incontinence. So the symptoms of the brain tumour will vary a lot, and it depends on where the tumour is in your brain. The rate of growth, how quickly it's growing. I think with a high-grade glioma like a GBM, you know, we're not really sure how long they've been there, but it's probably only a matter of a 9-12 week mark. So they're pretty aggressive, pretty fast-growing. And also depends on the size of the brain tumour. So where it is, the size of it, and how quickly it's growing. Your brain compensates amazingly. When I think about some of the imaging that we see and how people are walking around with things in their brain, your brain it's an amazing thing that compensates. Now this was just looking at the location. This is just to do with the high-grade glioblastomas. The IDH, which I think they've spoken to a lot about today, the IDH wild type or negative, they're in that subcortical white matter and the deep grey matter. But looking at the lobes of the brain where they primarily are, so about a third are in that temporal part of the brain, and it's probably good for you to know which part of the brain that your tumour's in, because it will make you understand some of the symptoms that you have. The parietal and frontal lobes about a quarter, and the occipital lobes at the back of the brain where the vision is about 16%. The IDH mutant or positive are predominantly frontal, as are a lot of the lower grade tumours. They're predominantly frontal lobe. So the reason that we're talking about different changes or symptoms within brain tumours, and it's around where your tumour actually is. So there's not sort of one main thing that'll give you a symptom of a brain tumour. It really depends on the location and how much swelling it's causing within the brain. So if we start right down at the bottom, that temporal lobe there, and that's really can be around a speech area where you're having trouble with word finding. It's a big seizure area as well, where people will present with seizures, and it can sometimes be mobility things as well. The frontal lobes is more around that high executive functioning, your intelligence, reasoning, personality changes in this area, and urinary incontinence can come from this area. If you see people that have got a lot of swelling in their frontal lobes, they tend to have that urinary incontinence. And then around to the parietal lobe, towards the back of the brain, that's around reasoning, telling left from right, and your comprehension of language. So you can read something, but you can't, and you can read it out loud really, really well, but you're having trouble comprehending what's actually, going on. Then the occipital lobe is primarily around vision, so you'll lose complete or part vision in the area. I actually saw this morning on the news when I was coming in, they were talking about new movies that were out today. And there's a movie with a great, I thought he was French, but it turns out he's Irish, actor called Gabriel Byrne. And he gets diagnosed with an astrocytoma in the parietal lobe. That's the clinch of the movie. And it's basically what he's going through. It's around that occipital parietal lobe, but he is hallucinating a lot. So the movie's actually around the hallucinations and things he's seeing. So you can get seizures in that back part of the brain as well, and they can be a bit bizarre where you do see things. I've had patients over the years that have seen broccoli float by and stuff like that. So different parts of the brain will do some weird and wonderful things. And then the area right down the bottom, the grey bit, the cerebellum, is really around your balance and coordination. So people walk around like they're drunk, but they feel like they're walking straight. So depending on which lobe of the brain, what challenges you end up with. So it can be very varied. But I think it's good to know, as I said, where your lesion is, so that you kind of get, and the family or carers understand what the changes in symptoms are and why they're occurring. So just touching a little bit on the cognitive issues in these areas. So obviously that front part of the brain is around attention, concentration, that high executive function, so it can be a challenge where, and a lot of the patients I see look very, very normal, look like everybody else, but sometimes their processing of information, attention, that part of it can be a challenge. The working memory and learning new things more so, and that visual spatial function area at the back of the brain. So just talking a little bit more about the cognitive function. So a lot of the patients that I see tend to have problems with short-term memory function. Long-term will be very good, so bringing up stuff that happened 30 years ago and really good about that stuff. But what's happening here and now in regard to medication, appointments, timing of medications, when your MRI is, that sort of thing can be a bit of a challenge. And again, the difficulty with comprehension and attention, so understanding what's going on and why things are happening. Some patients can be a little bit irrational, and that can you know, your medications that you're on can come into play with that as well, but will also lack insight. So where you've got somebody who's wheelchair bound, but they keep asking when they can get back to driving and things like that. The poor ability to plan, make decisions, realise the importance of certain tasks. So you've got a carer that is saying we need to get to this appointment at 10 o'clock in the morning, and the patient's sort of still, or the person with the brain tumour is still languishing at home at 9:45 in the morning, and they can't see the importance of certain tasks. And the loss of word finding or any speech issues. As well as that, again, that altered visual, spatial and construction skills, the sensory and perception functioning, the language, memory, mood, thought, content, personality behaviours, and again, that high executive functioning and intellectual functioning. So I suppose the thing with brain tumours is you've got, you know, the actual brain tumour that's causing a problem within the brain, within a particular location of the brain. You've got a lot of swelling potentially around that lesion as well. You've got side effects or changes because of the tumour itself, because of surgery that you may have, you know, where things change. People sort of come out of surgery sometimes a bit concussed and a bit fluffy-headed for a couple of weeks, and things then settle down over time. But also then we go in and we treat people with chemotherapy, with radiation, and these have changes on the way people feel as well. So, you know, those initial side effects of treatment, not with chemotherapy, this is more around radiation effect. And, you know, usually pretty minimal, but the main thing here with the radiation is around that increased cerebral swelling or cerebral edema that Dr. Back was talking about. I find can be in the last couple of weeks of radiation, or that first 4-6 weeks after radiation when we do that initial MRI, but it can be anywhere sort of up to 8 to 12 weeks afterwards. And you could be fine when you come and see us with an MRI at that 1 month after radiation's complete, and then things change a couple of weeks later. And it's all got to do with that swelling within the brain. And then the long term, just touching on that, I think that fatigue is one of the biggest things that changes your cognition and comprehension and how you know, manage your brain tumour. And this can be immediate fatigue or this long-term fatigue where you just feel quite fuzzy and you're not taking information in as quickly as you normally would. So this edema or brain swelling that we keep talking about, so as you know, your brain's in a closed box with an inbuilt helmet. So if you've got something going on in there that's not really supposed to be going on in there and there's not much room for movement, some change is going to occur. And it can be seizures, it can be more sleepiness. This patient here, he had a glioblastoma. It was a very extensive glioblastoma. They resected it, and this is his MRI a month after he completed radiation. So you can see the white changes on your right, is a lot of swelling in the brain. And this patient's family were ringing me in the couple of days leading up to this scan, and they couldn't wake him up. He was very, very sleepy. And so we had to give him some dexamethasone, and the dexamethasone relieved the swelling in the brain and things improved, and he was actually able to come in for the scan without too many issues. So the swelling in the brain can cause some massive changes which needs really pretty quick attention. So talking now a little bit about the things that we use, medications that we use for the symptom or the effects that we've either the brain tumour's causing or the treatment that we're causing on the brain tumour, and some of the issues that these drugs can, sorry, that's the work phone going, some of the issues that the drugs can actually cause. So you're using something to control one part and it's causing something else. So dexamethasone's the only drug that we have to control that swelling in the brain. If we don't get the swelling under control, it can be pretty dire outcome. But we're desperately trying to get people off dexamethasone because it has a whole multitude of side effects that can, make your quality of life pretty bad. So the main one that we constantly go on about is that muscle weakening or wasting, where you end up that you can't actually mobilise and get around because you just don't have the muscle capacity or strength to do it. That increased appetite and increased weight gain, more fat rather than muscle, can also make you retain fluid. The skin fragility, so when you see people that have been left on dexamethasone for many, many, many months, they end up with little bruises and skin fragility, and the skin can become pretty paper thin. The anxieties or dexamethasone psychoses that can occur with high doses of steroid, and the poor sleep, where you're absolutely dog-tired and really need a good night's sleep, and you're awake, an hour or two after you've had your dexamethasone. So these are some of the side effects of the drugs that we use, but that we need to use. And also the issues around diabetes or increasing your blood sugar, and things like thrush and pneumocystis, herpes zoster. It brings those things on a bit easier as well. And then I wanted to touch on some of the drugs that we use to control seizures, because, a lot of patients, some of them aren't on anti-seizure medication, but throughout the course of your treatment or diagnosis, a lot of people are. We can cause allergies to anti-seizure medications. Some of the newer drugs aren't too bad, but things like Dilantin that was used many years ago, people would come out with a terrible rash, but newer drugs like lamotrigine can cause the same sort of things. The medications can be affected by other drugs, so when you're increasing or decreasing steroids, you're changing the levels of your anti-seizure meds, and managing mood. So I think more so than the titrating the level of the drugs now, we don't see that so much with the current medications that we've got, but a lot of the current medications that we've got can cause some pretty terrible mood in people, where they can get terribly depressed, angry, suicidal thoughts, and those things need to be managed. I saw a young guy, and he was on Keppra, and he was on a small dose of 500 morning and night. He had a seizure. We increased the Keppra to 750, which still isn't a massive dose, and he was going to punch a wall in. He became, that small increase of that medication just made things quite, angry and agitated for him. So when you're a carer, you're a family at home, it's pretty hard to manage those sorts of things. And then some patients are on multiple anti-seizure agents to control their seizures, sometimes up to 4 medications. And that can make you feel pretty fuzzy and pretty numb in the brain, and people will say that, their thinking and clarity just isn't as sharp because of the medications. But it's a bit of a catch-22 because you need the drugs to control the problem. So what can be done? Because there's a lot of negative stuff there. I suppose a lot of it is getting support from your care coordinator to help you manage some of these things, which then leads to early intervention to medical staff. I think as a care coordinator, I probably advocate a hell of a lot for the patients that I see and the carers that will ring up, and I'll harp on to the doctors that maybe the drugs we're using aren't the right medications. But also link into things like emotional wellbeing for the patient and the carers, so clinical psychology, counselling, that sort of thing. When I started my job, I didn't think I'd do as much counselling. I'm not trained in counselling, but a big part of holding a phone and being accessible for people is that, emotional support. And, I'm happy to do that, as a lot of care coordinators are. But I think, it's also realising that you need to refer on to the correct people as well. And that goes on to that, psychosocial assessment and the provision of required care. So getting to the appropriate people that are better trained than myself to help people in that area. Referring to allied health, rehab, social worker, getting access with all the paperwork for ACAT and NDIS. Rehab for us now, and something that I've seen change over the years, as Dr. Back was saying earlier on, you know, it was a little bit nihilistic for brain tumour patients, but it's a massive benefit. If I can get somebody into a rehab team and get them seen, the benefits for the patient cognitively and physically are mammoth. You know, it's a really, really important thing. And I mean, I have to say, I'm in an area of Sydney where we have really, really good access, and so the access to rehab's not always so easy, but it's something that you really need to push, you know. And as I said, the early intervention to the medical staff and educating people. I'm a big advocate of educating people and trying to get them to understand why symptoms or changes are occurring, and, you know, getting them to understand their MRIs and why things are happening, because I think if you can understand why things are happening, you tend to manage them a little bit better. And that comes into also what Dr. Back was talking about, was the carer mastery, making experts or semi-experts of the people that are the carers, to enable them and encourage them to, you know, enact. That's a big part of what we do. So I just wanted to talk a little bit about what's actually out there and what's available, and this is many, many years old, Liz, 10, 11 years old, something maybe. And there were a whole heap of fact sheets that were put out through the Cancer Institute. They're a bit hard to find. I think they're on the BTAA website. We put them on there. And there's a whole heap of them. This one was around memory, and really it was around educating the patient, but also the caregivers around issues that patients with brain tumours face. And this was another part of the educational thing that I was talking about. So there's a whole heap of these fact sheets that are available that are just pretty useful from an education point of view. Of course, the Cancer Council support, they've got the telephone support groups, but they also have the practical and financial. I think when you're nearly done, Liz? Yes, she is. That's what I was just going to say. And I think as Dr. Cole is going to do rehab, we've also got Cancer Council after me, so it ties in nicely. You know, if you're under financial stress and getting a lot of pressure from work, it's a massive, massive change for you when you've been diagnosed with a brain tumour. So support systems like this and advice. And you know, they do pro bono work, so it's good to try and access these things. Of course, the support groups, that's your plug. The resource that came out 2 years ago now, was it 12 months, 2 years, with the booklet about, you know, it's okay to ask. You know, we're all time poor, but it is okay to ask, and you write your questions down when you do see your health professional so that you can go through things. And the final thing, which it's not going to turn up on the slide today, was recently one of our patients, she's probably 30 or 40 years of age, working as an accountant, managing a group of about 60 people, couple of kids, and she got diagnosed with a brain tumour. And she saw an opening where she felt unsupported, and she's come out with a bit of help from some health professionals and launched this survivorship diary recently. And I'm just going to, thank you, she's on the front page of the BTAA book. Her name's Cassandra Bennett. And she's done a great, great job. We released the book recently with, because it's Brain Tumour Awareness Month, of course, everybody knows. And I will get out of here because I've got the guy might have to help me. Can you help me get out of here? I don't know where the cursor goes. I know you're telling me it's on a different thing, but I cannot see it. Just shut that one down for me. There it is. Just close it all together. And I'll open up this one down here. So I just want to talk, whoops, get out of there. Oh, you bugger. Yeah, it's not showing. It was the thing that I put up. So as you can see, though, that was from the help of a whole heap of people. I think Cass dragged in friends of hers that were, you know, visual people, and they've done an absolutely brilliant job on this book. And the whole idea with the book is talking about survivorship. And Cass said to me at the beginning when we were working on this book that she really wanted it to be given out at, you know, neurosurgeons' surgeries, but not everybody goes through a neurosurgeon's surgery. But my other point is you can pick this book up at any time and it's going to be relevant to you. So it doesn't need to be from the beginning to the end because things are ever changing. And really it was around that whole survivorship and, you know, what is survivorship? And it's really around the focus on the health and well-being of people and their families who are living with, through and beyond cancer therapies. So that's what the whole domain of survivorship is. It's been a bit of a buzzword over the last few years because people are living longer. So you need to support them. Now, the brain cancer survivorship, as Cass says, starts at the diagnosis, but it goes through. But as I said, you can pick this book up at any time, and I think you're going to get absolute value from it. It was put together by Cass as a patient, and a whole heap of medical people put their time into supporting this book and going through it. But it's really, as she says, a short summary of the different stages of treatment, different questions that you can ask your medical team, forms that you need filled in, your work, you know, your return to work, your driving, your accessing super, you know, all these sorts of things, terminal illness claims, all of that sort of stuff. And then a checklist for hospital packing, you know, what to put in your bag each time you come in as an inpatient, little things like that, different insurance details and calendars. So, okay. So it goes through different stages. As you can see, there's all these different stages down to number 10. But really, even if you pick the book up and you were starting chemo, you're going to have benefit from it. I don't think it's going to disadvantage you at any time. And just a little bit on how to actually get the book. So these are free at the moment. She will send you one of these out. You can actually get it in a hard copy or a soft copy. You can download it and read it on your computer, or they will send you one out. If you just go to the www.survivorshipdiary.com and they will send you one out. I actually went on the website yesterday and ordered myself one to see how hard it was. And it is a bit tricky because you go to the order your free copy, you put your details in that, and then you've actually got to go back up to the little shopping basket up the top to then finalise. It's free. It comes up through a bit of a process of paying, but you actually pay nothing and then they mail you this out. So if you want that, that's a way of getting it. And I've got just this one here today if anybody wants it, because I'm not taking it back to the office. So that's all I had to say. I just wanted to bring up this great other resource that we've got for brain tumour patients. Sure?
We've got time for one or two quick questions. Does anyone want to ask Marina anything? Don't have a roving mic, so you don't have to speak up.
All quiet on the home front.
I'd like to thank Marina very much.
No problem. Once again. Oh, there it is. Who's next? Is it Cancer Council? Oh, you're going up? Okay, I'll leave it to you.
Some of you may have noticed Kaye Duffy was listed to be doing this afternoon session. Kaye has been involved in this forum since conception, and since Adam was a boy, and she is just a driving force. I got a little message a little while. She didn't want to travel down from Newcastle because of COVID on public transport, and I understand that. And she sent me a message to say, "How's it going?" You know, she really would love to have been here. I'd like to welcome another stalwart of this forum, Professor Andrew Cole. He's a rehabilitation specialist, and as we've been hearing today, it's the big buzzword of how to improve your lifestyle while you're going through your journey. I believe that you were a pioneer in proving that rehabilitation for brain tumour patient works. They'd done a lot of work in the past on stroke victims, but they hadn't bothered to do anything, and Dr. Cole did all that research, and he may be telling us a little bit about it today.
Yep.
Thank you so much for coming.
Thank you, my pleasure. Now, how do I get this thing up? Where's he gone? Oh, hang on. I think I can see it.
Andrew was one of our first members of the New South Wales Neuro-Oncology group back in 2001.
How do I get it on screen?
Supporting one another.
Good.
He's been right from the get-go.
Okay. Well, it's good to be here. I got into this by mistake. 30 years ago, grey hair. Actually, it's from teenage children, whom I think all had brain tumours when they were young, because they always went to sleep all the time and never wanted to get out of bed in the morning. Anyway, 30 years ago I was working in Taiwan, setting up community-based palliative care and community-based rehab services. I had a group of patients that were neither rehab nor palliative care, in that they lived for a period of time. So I started looking up what was written about cancer rehabilitation. And in the early 1990s, the number of papers on cancer rehabilitation could be found on the fingers of one partially amputated hand. 3 papers, significantly only. So when we came back to southwest Sydney in 96, we started getting up and trying to see if there was a model that worked. And of course, as we now know, there is. Because the central issue that I'm passionate about is, what if there's impairment or disability after you've had primary treatment for brain tumour? And if you look hard enough, it is very common. Very common. I'm sorry to teach you how to suck eggs, but you know what I'm getting on about. And the classic picture, as Marina has worked through, one of the classic pictures is it looks a bit like a stroke, or parts of a stroke, in different parts of what the person can do. Weak arm, weak leg, speech problems, can't shower, can't dress. But then there are the less obvious problems like thinking, logic and reasoning, mood problems and so forth. And those are all rehabilitation problems, because we've been looking after stroke patients with those problems since Adam was a boy. We've been looking after fractures. We've been looking after people with spinal injury problems for a long, long time. So in the same way that those problems respond if the stroke is the cause, they also respond if a brain tumour is the cause as well. So the message I want to pull right out there at the front end is, if you have problems with those areas in your functional, ordinary daily living, ask to have them assessed. Okay? Marina's dead right. She's always right. Ask to have them assessed. Ask to have them assessed. Now, the rehab specialist is part of a team. So the rehab specialist either works in a hospital or in a clinic, and they'll sit down and they'll do a full history and a full physical, and they'll find out about what you're like as a person. And a lot of the times I sit down and I spend a full hour with my patients the first time I meet them. They come out and they say, that's the first time anybody's asked me any of those questions. I'm thinking, what on earth were the other people doing? They were probably thinking about important things like, what's under the microscope or something. But we know that what's important to us personally is the story of our life and how this particular illness has affected my life, and what I want to do about getting that fixed up. So we have physios on our team. They obviously look at muscle and mobility control and balance and endurance problems. Occupational therapists look at what you can't do or need to do with your daily life, starting with basic things like washing and showering and dressing, because it's surprising how often people will go home from hospital and they can't do some of those basic things, but they look okay. They may be relatively young, relatively fit, they've got a family to look after them, and everyone thinks, okay, off you go. But if you can't do it for yourself, somebody else has got to support you, and that takes their time and effort. Feeding, cooking, shopping, leisure activities. Speech therapists look at 2 things. They do look at communication, but they also look at swallowing problems. And if your tumour's in the brain stem, swallowing problems can be a serious part of the issue, because you can actually get into trouble with chest infections if food goes down the wrong way. Nothing to do with the brain tumour. Everything to do with the swallowing as a secondary result. And the social workers, as you know, look at family and care network issues, finances, and how you're getting in community. And out of all that, after we've sat down with a person, and members of my team have sat down with the person, we discuss what the person wants to do with the problems they've got to get to improvement with therapy, to get on with providing the right therapy at the right time, in the right place, in the whole process. And sometimes it's in the acute hospital when the person's still having treatment. Sometimes it's immediately after the surgery and they've got significant problems, they're not quite starting radiation treatment, and they'll come to a rehab unit and they'll have rehab therapy and radiation therapy together within the same program, so that we're actually seeing and improving things. Sometimes it's after discharge, when problems only really become apparent when a person is up to doing complex things for themselves and they then fully realise what their deficits are. And then we review the effects of all the therapies provided on a regular basis. So, practical example, getting around in the community. Everybody wants to get up and about. Everyone wants to leave hospital. The only people who want to stay in hospital are definitely usually those with mental health issues. Everyone wants to get out and go home and get on with life, don't we? So when you want to get out and get about after medical care, the first step before you even think about driving a car is getting into a car and getting around with somebody else driving you around. And that can be quite a complicated process, because you have to think about how do you get to safely move to the vehicle. Are there steps at your house? Are there uneven pathways, uneven surfaces? If you have any degree of mobility difficulty, how do you get into a vehicle? And if you're my height and I have a mobility difficulty, I have to tell you, getting in a Toyota Camry is really difficult, because they look terrific, but your bum's on the road, okay? And you're sitting right down. So not for nothing do I drive a mid-size SUV. It's about exactly, it's a VW, so it's designed for tall people who are Germans like me. And it's easy to get into that. You just back your seat up, park your bottom on the seat, somebody swings your leg in, you're in the car and off you go. And being properly belted in is important, and one of the things we find when people get up and they get going is often motion sickness becomes a problem. And until you're in a car and you're trying to get around, you don't realise you've got that problem. But boy, it can be a problem. Is it to do with your upright posture and a fall in blood pressure? So you have a look at the medications, the fluid intake, the output balance, whether they're on the dreaded dexamethasone. And if there is a blood pressure drop problem, we can stick you on a tilt table and retrain your blood pressure reflexes. Sit you up to 30 degrees, drop you down again. Sit you up to 70 degrees, drop you down again. Or is it related to a problem with your 3D movement head in space? Okay, it's this kind of a variation of what happens when you get seasick on the outer islands cruises off Cairns. But the things that we need to check are the ENT basics. Is there hard wax in there? Because nobody's done that for a month or two while everything else has been going on in hospital. Do you have a blocked middle ear for some other reason? Or are there problems with the brain stem, with eye movements flicking to one side worse than the other? And cyclazine will help that. But if you do have motion sickness, it's like going out on a boat to the outer edge of the reef, stand at the front, fix your eyes on the horizon, because the horizon doesn't move. The boat moves, everything else moves, the sea moves, the horizon doesn't move, and you get rid of the flicking sensation. So if you're sitting in the front seat as a passenger, looking at the road ahead, a fair way out, that will often really help motion sickness as you're driving. But people want to drive again, and this is the part of rehabilitation everyone wants to talk about. Driving is a really complex task, remember? First time you learnt to drive, the most important thing about learning to control a car is to use your hands and feet independently without looking down. It's a bit like playing the piano. If you've got to look at the keyboard all the time and not look at the music, you're never any good as a musician. Well, you might be able to play by ear like some of my clever members of the family do, but for me, I've got to look at the music because my memory's not that good. Incidentally, I lose my keys regularly. I can't remember people's first names and all those things happen. So it's important to remember that memory problems are actually on a spectrum between what's normal for your age and what has been affected by your disease. And a person who is 60 or 70 with memory problems may not in fact get back to the memory of a 30-year-old, much they want it, because I can't do it. I'm forgetting things all the time. I've got to think as I go out the door. Phone, keys, pen, lunch in my bag, and my laptop. Anyway, so you've got to learn to control the car with your hands and feet without looking down. You've got to keep the car in the right place on the road. Now, my new VW, 2 years old, is a nanny car, and so it beeps when I move out of the lane if I've got the switch on. You've seen those little things that looks at the lanes on the road, which is really irritating when you want to change lanes quickly on the airport expressway to get to work in the morning in some sort of reasonable time. But I need, when I'm driving safely, to be aware of my speed, my position, how close other cars are away, and judgment and depth perception can be very severely affected by brain tumours without us realising it till we get in that situation. And we need to be aware of other road users, not just cyclists, but other cars. Safe distances. We don't have physical contact between vehicles. You know, we don't do the dense Asian city parking regime, which is to move in till you bump the back and then move forwards till you bump the front and move back and bump, bump, bump and you get in. We are a no-contact driving community, and all of those things are really important. Needs eyes, needs ears that work, needs cognition, needs good muscular control, needs good thinking and good judgment. And it's really important socially, because in many places, if you haven't got a car, you're in real trouble. I'm in real trouble depending on public transport. I live down the bottom end of Oakley, which is just lovely because it's quiet. Nobody goes there unless they're going there. Okay, there's no through roads through that part of Oakley. But there's only 3 buses a day down there, and it's about 1.5 kilometre walk up to the shops. So if I can't walk and nobody else can drive me, I've basically got to get someone to come down and pick me up with a taxi and so forth, if I can't drive. The other thing is, particularly for blokes of my generation, and increasingly, 10, 20 years down for everybody, men and women, driving a car is a really big part of our social identity. Okay, it was big that I got a licence when got my learner's permit when I was 16 years and 9 months, and got my licence when I was 17, so I could drive my dad's car wherever I wanted when he wasn't using it on a Saturday night with whomever I wanted. And we could go in those days to the drive-in and do all those things that we used to do in those days. And it's a very important part of our personal identity. If we suddenly can't do it, that's a part of our personal identity we lose, and that's something that makes any normal person feel down. We can't do it. The thing though, however, that driving a car legally, it's a privilege regulated by law. It is not a universal human right. Okay, it's not like the Americans that have the right to life, liberty, and the pursuit of happiness, which I think is an oxymoron, but that's another story. But driving is not part of that constitutional rights for them or for us. I mean, we haven't got a constitutional right for anything, but even so, that's the way it is. And driving is a triangle of responsibility. The person driving the car, the healthcare worker that looks after the person driving the car, and the driver licensing authority. Those 3 work together. So as an individual driver, we all must ask ourselves, do I need to drive? Apart from want to drive. Do I need to drive? Because that's an important question to ask about. Increasingly, not everybody expects to drive a car, just anyway. But after something like a brain tumour with disability, do we need to drive? And the reason we need to ask that question is if we have a crash, we're the primarily responsible person, and the police come and ask us to explain why we couldn't maintain a non-contact situation from another car. I was looking at my mobile phone, officer, sorry. Anyway, so if we have medical problems that are likely to impact on our ability to drive, at law, we are required to disclose those to our medical attendants, doctor, GP, specialist or whomever, and to the licensing authority that issues that bit of plastic or the virtual thing on your phone that says you're fit to drive. But to acknowledge medical problems, we also need to have insight to know we've got a problem. And our insight is this magic thing that develops up to the age of wherever you are in mid-teens, 15, 16. And after that you've got it, and if you haven't got it by then you're never going to get it, I'm sorry. But we have to have insight, and one of the things that's difficult about brain tumours, particularly in the frontal lobe, is that we know that people don't always have insight. into the full extent of what's going on. And the insight can be the husband or wife who won't get into the passenger seat if you're in the driver's seat because they don't trust you to get them there in one piece, both of you there in one piece. But a driver with chronic medical problems, whether it's a brain tumour or diabetes or renal failure or anything, has to report these to the doctor and the driver licensing authorities. The healthcare worker, Marina, me, Liz, other people are involved. Our question is a different question. Our question is, as we're working with you as a patient, is this person a safe person to drive a car? Is this person a safe person to drive a car? And it's professionally responsible for us to think about the effects of your illness on your daily life. And there's really big ethical dimensions here. Really big ethical dimensions here, particularly for GPs. Because the good old style family GP that's been sitting in that pair of rooms for 20 or 30 years, looking after you for 20 or 30 years, has real difficulty saying to you eventually, look, I think the time has come that it might not be safe for you to drive. Because saying something like that can really rupture a relationship that's been built up over years. We see it very commonly with people with dementia, where we know the problem's going to keep going and keep developing no matter what happens with treatment, unfortunately, at the moment. And those people have often had 40 and 50-year relationships with the GPs. But it's up for the health worker to assess the effects of disease on functioning and to advise impartially if, in my professional opinion, it is safe for you as a driver or not safe for you to drive. And we have a report to the driver licensing authority if a person who is unsafe, and especially if that person is ignoring professional advice not to drive. Because if I don't report, X is still driving when it's not safe to drive, and that person has an accident, there is now legal precedent that they can come after me as not really noting what should have been noted in that situation. Not easy. The driver licensing authority in this state is an allegedly intelligent life form that lives on the other side of the Blue Mountains, somewhere I think at Bathurst. They used to live in every little motor registry office, but then they turned them into Service New South Wales, and instead of issuing driver's licence or as well, you can now get birth, marriage, death certificates about everything under the sun. So the main authority now is Bathurst or Orange or somewhere like that, and their question is it legal for this person to drive? And they're the decision makers. They get information from the patients, information from the healthcare workers, and they basically run through a tick box pro forma of standards, and they either issue a licence unconditionally or with conditions or not. And the licence state X is safe to drive, full stop. Or they drive with conditions. Now I'm at the age, late middle age, where my licence has a condition on the back that says I must wear specs when I'm driving. Okay, another 10 years when I get my cataracts done, I'll get multifocal lenses put in and I won't need to wear specs, which will be a great deliverance. But for the moment, I've got to wear specs. But the licence may be endorsed, may not drive more than 20 kilometres from home. Or it may be endorsed, may not drive in darkness at night. Or it may say, not safe to drive. They punch a hole in it and send it back to you and you can use the identity document, but you can't use it to drive. And if you or I drive in contravention of conditions that are on our licence, there are legal penalties for that. There are legal penalties. So thinking about assessments, the three major concerns. And if we're thinking about a person getting a licence back now, they're not the same concerns as they were when I was 17 or 18, because when I was 17 or 18, I was presumably young, fit, slightly crazy, but my distance perception was fine, my vision was fine, my ability to remember new road rules was fine, all that stuff cognitively could be assumed to be pretty good, that I had the physical and psychological ability to control the vehicle, especially if not under the influence of some other chemical. Okay, all of that was assumed, and that's not necessarily the case now. I could have assumed in the old days that I could get in and out of a car when I was 17 or 18 without too much problem, that I could grip the wheel, that I could do all those things, that I could actually learn how to drive without looking at my feet and my hands. That's not necessarily the case now. And if a person after a brain tumour has one hand that doesn't work too well, then the vehicle's going to need to be modified. or if they've got one foot that doesn't work too well, we'll need to have the pedals modified and you're not driving a manual car anymore. The other thing is the ability to recall and apply current road law, because the road laws as they exist now, I have to tell you, are not the same as they were when I first learnt to drive. Take a deep breath, 50 years ago. Not the same at all. We used to have a give way on the right rule, where you could be driving down a really big road and somebody could charge out of a side road and you had to give way to them. Awful rule. They got rid of it and they replaced it with roundabouts, which are just about as confusing, because if you can work out when you're supposed to put your left-hand indicator on and your right-hand indicator on when you're going in and out of a roundabout, you're probably a better person than I am. But there are road rule changes like that. There are road rule changes about you've got to give distance between cyclists and the car that did not exist 5 years ago. And a lot of people still drive as though they don't exist. Okay, there's lots of road rules that have changed. In fact, if you got your driver's licence before 1958 in South Australia, you didn't need to know any road rules, probably because there weren't any road rules in South Australia in those days, but that's another story. So practical steps, if a person needs to drive, what am I going to look at? I'm going to do a full medical and driving history. Have you had crashes before? Do I think you're fit to drive or not drive? What do I think about the person's insight? I examine and document clearly the conditions and anything else that's going on, and I make a decision in my mind and I recommend to the person, yes, I think you're fit to drive, or I think you need to have conditions, or I don't think you're fit to drive at all. Sometimes I may not be able to fully make up my mind, and I may recommend that you go along and get a formal test done at one or other of the places that does driving rehabilitation. There are 2 in Sydney, there's 1 in Newcastle. And I talk about the result, and I talk about it with the person, and usually their family and their carers are present at the same time. Really important that everyone knows what's going on. Because you and I both know it's a bit like people watching a traffic accident. 2 people on opposite sides of the road will have a completely different view of the accident. Okay, a pair of, a spouse and partner coming out with the patient after a consultation with the doctor can have 2 very different views of what was communicated then, simply because one will hear particular words and be so fixated on those words, naturally speaking, because they're the one with the illness, that they won't take in a lot of other stuff, whereas the partner might take in an awful lot of other stuff around the side. It's important to triangulate that. I make a report to the Driver Licensing Authority, and it's on that green form, whether conditions apply, whether a further review is needed, whether it's cancellation, and I continue follow-up because brain tumours are dynamic. Things change. So the cognitive problems or the vision problems that a person has one day might be quite different 6 months or 12 months later. So specific problems to think about in New South Wales, and the exact interval times may vary. If you've had a blackout, the general rule for any cause of blackouts in New South Wales is you're not to drive a car for 6 months afterwards. So if you have an accident, you want to get out of it, it is a bad idea to tell the police that you had a blackout because they're going to cancel you for 6 months. Okay, own up to the fact you were distracted by the pretty girl walking down the road, or in the case of my daughter, the pretty dog running down the other side that looks like her pet dog at home or whatever. If a person has epilepsy, if it's a first fit and the fitting is successfully treated, generally speaking, if a primary cause is found, they should not drive for 6 months. If there's no primary cause found, which is not the case in what we're talking about here, shouldn't be driving for 12 months. If a person has significant neurological deficits after surgery, the prudent thing is not to drive for 6 months after surgery, though some neurosurgeons will re-examine a patient after 3 months and say, I can't find any more deficits now, I'll sign you off after 3 months. Good? That's that person's decision and responsibility. I'm a little bit more cautious. If a person has visual field problems, either they can't see at all in one visual field, or when they have stimuli coming at them from both sides, they extinct one of those 2 stimuli, you're never going to drive again. Because, think about it, if you're driving up the road outside, whichever hospital, Greenwich Hospital in my case, and the primary school's on the opposite side of the road, and you're driving up the hill, at the end of the day, and there's a bus coming down the hill, and you're looking at the bus coming down the hill, and he's in the right-hand side of your field, because in this country you drive on the left-hand side of the road, and a kid kicks a ball out and runs out from your left-hand side, if you cannot see those two stimuli simultaneously in both fields straight away and respond to them, you're a dangerous driver. I'm a dangerous driver. So sensory extinction is not something that people realise they've got. You only realise you've got it when people give you two stimuli on both sides and you can't see one of them. You can see each of them separately if they appear as a single stimulus. But if they're presented together, people miss that. It's really important. Visual acuity. If your visual acuity is, it's got to be 6/12 or better with specs. If you've got more than 20 degrees of central field loss, that's like driving with your fists in front of your eyes like that. You can't actually see what's in front of you. If your visual fields are less than 110 degrees, and that's when you've got half a visual field missing or something like that, you can't do it. And if there are patches of visual field loss, you shouldn't be driving. With a brain tumour itself, just by virtue of the tumour itself, if a person has got cognitive problems, neuropsychological impairment, that means, for example, that their ability to react to something quickly is impaired. If you've got to take 5 minutes to think about whether the kid running across the road you're likely to hit him, okay, that's not a good way to be driving. My oldest boy told me he wanted to be a doctor. I said, Dan, you'd be a useless doctor. He looked at me somewhat, I said, you take 5 minutes to make your mind up. Okay, you'd be a great civil engineer, which in itself is an oxymoron, but you'd be a hopeless doctor. Think about it. You need that reaction time if you're going to drive. Now, he can actually drive a car, thank goodness. So to make those decisions, it only takes him 10 seconds, where I'd take 5. But if you have that sort of problem with reacting to things cognitively, it's important. And generally speaking, after diagnosis of malignant brain tumour, it is not appropriate to apply for a commercial driver's licence. Because commercial vehicles are large, heavy, they're difficult to control, they take a long time to slow down, and if they're a bus, they involve 40 or 50 other people behind you driving it. So after a brain tumour, if you're going to try and get a licence back, you're going to try and get a car licence, if anything, not a bus or a truck licence. So the steps for driving: full assessment, physical exam, visual fields perception, cognition or judgment. If I'm worried about road rules, an off-road rules test, which is a computer test, and if I'm really worried that they're borderline, but I'd love to get them back, but I'm not sure, I'll send them for on-road testing. Now, the last two are not covered by Medicare. They cost about $1,000. I have to tell you, however, I have 4 children, and to stop my hair going completely white by the time I was 55, I sent each of them off for 10 hours of driving lessons before I sat beside them while they got the other 140 hours to get their licence, okay? And I have to tell you, by the time you pay for 10 hours of lessons for one kid, you don't nowadays have much change out of $1,000. It's a privilege regulated by law. It is not a human right. Okay, so longer distances, and I'll finish up in a sec. On the surface, bus or train, a couple of hours. If you're travelling longer distance, you need to think about the check-in, getting onto the vehicle, where's it like, getting to the seat. Generally, I say if you can get somewhere by train for a journey of more than a couple of hours, even Newcastle, it's better than trying to get on and off a bus, because on a train, generally the access is a whole lot better. Okay, platform, you often got a little man or a woman that'll push a ramp up. The train will stop for an extra 2 minutes. Everyone's hanging out to see what's going on. But you can have a wheelchair or a person who's a bit, not sure in walking, have time to get in, get to a seat, especially if you're travelling for a couple of hours. The longer distance trains beyond the Sydney metro area in Sydney have got toilets. So you can actually go to the loo without having to get off at Asquith and wait for the next train after you've gone to the toilet. Disabled accessible toilets are usually present. The longer distance trains have got better toilets. But the other thing is, if you're going to travel longer distances, that's the kind of situation you really, if there's any degree of need for support, have a person with you. Really important, really important. Air travel. Now, I used to spend 3 slides talking about this up until 2 years ago, and I look at that and I think, oh my goodness, when are we ever going to get long distance air travel again? Okay. ScoMo says, well, maybe not before, July the 1st, 2023 in the budget, 2022, and even travelling inside Australia is an issue. Okay, we went to Perth for the Anzac Day long weekend for my oldest grandchild's birthday and the school musical, and we landed and they said, Mark McGowan's making an important announcement. I thought, oh, here we go. We were locked down with our grandchildren for 3 days, which was really good. Played a lot of board games, but it's unpredictable. Those things happen. So, but if you are going to fly, you do need to think particularly about companionship on flights and the access to toilets, both on the ground and on the plane. Because most of the aircraft that are flying domestic services inside Australia do not have proper disabled access to their toilets. Okay, I have trouble peeing inside a 737 toilet because apart from anything else, I'm usually standing like that and, trying to sort of adjust everything in a very small space. The only ones that do are some of the Airbus 330s that Qantas flies on longer routes, if they borrowed those aircraft from their old international routes. The 330-300s have got a double disabled accessible toilet at the back of economy class. The seats are cramped, worth thinking about upgrading. If you're going to be on the plane for more than an hour or two, use your non-existent frequent flyer points to do that. The other thing to remember is that if you're on an aeroplane, it's a mountaintop experience. The cabin pressure is set at 2,500 metres. So it's like going to the top of Kosciuszko, or Kosciuszko as my Polish friends tell me it should be pronounced. It's like going to the top of Kosciuszko and staying there for however long the flight takes. So staying at the top of Kosciuszko for 4.5 hours and see how you feel, ordinarily, let alone if you're on the tail end of brain tumour. So, to summarise, brain tumours, rehab, driving and travelling. As a health professional, those that are looking after you, whether it's the primary care team, the rehab team, the physio, the OT, the social worker, the care navigators, we need to know thoroughly, impartially about you so that we can give you a good, honest assessment. Because that's what everyone wants, a good, honest, transparent assessment. We need to know the legal realities, both for people who've got brain tumours as survivors of that, and the doctors particularly, who are the ones that carry the can legally. Okay? Allied Health say, well, actually, I work for the doctor. So I make darn sure I know what they're telling my patients. But it's really important that we know what our liabilities are and where we're doing. And the possible outcomes for driving are that you may not be fit to drive, or you may be completely fit to drive, or you may be fit to drive with limitations, not more than a certain distance, only in daylight hours, only wearing specs and so forth. And long distance travel by air may one day be totally possible, but even within Australia you need to think about it carefully, and like everything to do with brain tumours, ongoing follow-up is really important because things change. Mind you, people change. Thanks very much. Are there any questions? Yes.
Is that just for people who have had surgery or?
No. It's basically, look, it's not, and it's not even particularly for brain tumours. Every illness that affects anything to do with your ability to drive has got variations of the same conditions. So whether you've had surgery or not, so a fair number of people might have only had, say, a biopsy rather than a full excision, so that the radiotherapist knows what they're treating. Cancer 101, get a piece under a microscope, know what you're dealing with, and then you can get on with it. But even in that situation, it is possible, because of the way that glial cell tumours spread particularly, for neurone function in parts of the brain that you wouldn't think necessarily to have been affected, because the cells on the surface of the brain may be fine, but their deep connections to other cells have been interrupted. Oh, rightio. I nearly said lucky you, but that wasn't quite what I meant.
I rang them to let them know that I had one and they didn't care.
Oh, right, okay. How long ago was that?
It's changed 22 years.
Was that in New South Wales? Yes. Okay. I mean, in that situation, what should be happening is that whoever was looking after you, in terms of your specialist treatment, So whoever's looking after you in terms of your treatment, whether it was a specialist or your GP, should formally have worked through if there was any problems that could possibly impact on driving to say, yeah, these things affect you, or these things don't affect you, fill in the green form and send it in. Because even if the form says nothing affects you and it's sent in, that's a really important thing to be recorded, if ever there's problems in future. GP can do that. Yep, neurosurgeon can do it, yep. That's fine, that's fine, that's fine. Well, yeah, I hate to say this, but my general feeling in life is to stay away from surgeons if at all possible. And I mean, there are situations obviously where you have to have surgery, but understanding that any time surgery is done, it is a balance between the benefits of what may accrue as opposed to the negatives of what may accrue. And it's always, yeah, we hope that the balance is well and truly shifted one way. Yeah, that's great. That's good to have a surgeon like that. The best surgeons are the ones who say, I don't want to operate. Honestly, in a situation where that's the appropriate thing to say, they're the best kind of surgeon to have. Yep. Yes?
Quick question. Is it necessary to be assessed for blind, just domestically?
Not. Okay. Usually quick chat with your GP to say, what do you think about this? If you're relatively asymptomatic and you're walking around and doing all those kinds of things, and for the sake of argument, you've driven up the Blue Mountains and not had any problems at, Katoomba at 1,000 metres, then there's a fair chance you won't have a problem on an aircraft at 2,500 metres. So in that case, then any risks are the usual risks of being immobile for 2 or 3 hours and, not wiggling your toes and doing all those things that you're supposed to do. If a person is very disabled, I mean, the situation I used to see, because in Lower North Shore, at Greenwich we're down the bottom of the hill from North Shore. Clever health professionals at the top, practical health professionals at the bottom of the hill. A lot of our patients were Chinese or Korean, and after diagnosis, the one thing settled, the one thing a lot of them wanted to do was to go back and see family. And I know what they really want to do is to go back and eat Chinese medicine. And I could have told them it wouldn't work, but, they've got to find out for themselves. And so we would go through in great detail, but the issues were around how are you going to get from the curbside to the check-in, how are you going to get to wherever next. And if a person was having trouble walking, it's about a 1.5 kilometre walk, especially if you're gate 9 going to, San Francisco, or something, at Sydney Airport. And so if you can't walk 1.5 kilometres, how are you going to do it? And if you're in a wheelchair, then you need to have somebody with you, you need to have all that stuff done, and that requires chats with the airline. And if you're going to an airport that doesn't have gangways on the level, like 2/3 of the airports in Queensland, Gold Coast and Sunshine Coast, you've got to go up and down steps, or you've got to go up and down the food hoist. It's important the airline knows about that ahead of time. The other thing about anybody with any degree of disability on a plane, the rules are first on, last off. So you get in, you get settled in your seat, everything's okay, and then they let the rabble in, and then the rabble run out at the other end, and you get to walk out without being bumped by anybody else and people lifting bags out and tripping you up and all that stuff. Yeah. Good question.
Thank you so much.
My pleasure. Oh, thank you. Goodness gracious. Too good. Brain food.
I'd like to welcome our last speaker of the day, Sally Carveth. Sally is an oncology nurse and is involved with a counselling background. She's worked with the Cancer Council of New South Wales for 26 years, and she's been in the area of supporting people affected with brain cancer and also their carers. Sally runs the Brain Tumour telephone support service in our magazine, we've got a half-page ad. Yes, whoa! And it's a group, but I'm sure she'll tell you about it. Thank you so much, Sally.
Thank you, Catherine. Great. Thank you, Catherine. I'd like to start by acknowledging the traditional owners of country that we gather on today, the Gadigal people of the Eora Nation, and I pay my respects to their elders past, present and emerging. So thank you very much for inviting me to speak about Cancer Council support services, and I would actually just like to dedicate this presentation to Andrew Walker, who met Cancer Council, in fact met my colleague Kim, who's at the back of the room, in 2017 at this forum. And Andrew became a regular and long-time member of our telephone support group. Sadly, Andrew died last month, but he's in my thoughts today. So just looking at navigating cancer together, at Cancer Council, our strategic focus is improving the lives of people affected by cancer by offering them the right support services at the right time. We help patients, family, carers, friends, and work closely with health professionals who refer people to our services. We provide information and support across every stage of the cancer experience, from diagnosis through treatment, post-treatment, survivorship, and also to end of life. So I'm hoping that some people in the room will know of our 131120 information and support service, and that's often the first contact that people have with Cancer Council. This is a free and confidential service that provides evidence-based information and support for health professionals, for the general public, and for people affected by cancer. All 131120 staff have worked clinically in an oncology environment and are trained as navigators to point people in the right direction for their concerns. So when a patient or a person calls 131120, it gives them the opportunity to run through what's happening for them with a health professional. For many of our callers, this means being listened to, by being able to tell their story in their own time, to help unpack the issue, provide emotional support to them, helping them write down questions for their treating team, and putting in referrals for supportive care services to help them along the way. The consultants have a knowledge of both Cancer Council New South Wales services as well as other cancer support organisations. They help break down complex medical terms into layman terms, but do not provide medical advice and always encourage them to speak with their treating team. We help equip patients and their carers with information to have informed discussions with their healthcare professionals so they can decide on the best course of action in a collaborative manner. And in the past year, we received over 10,000 calls, and 1 in 5 people are referred to a Cancer Council service. So what are these services? So looking at practical support, we know a cancer diagnosis can be both an emotional roller coaster as well as a logistical challenge. People affected by cancer often not only have the emotional stress and worry about treatment, but also the challenges of getting to and from treatment. We offer practical support services that includes transport to treatment in regional areas, accommodation support for people who need to travel over 100 kilometres for their treatment and also their family members. We have information stands in many hospitals around the state, and they are manned by volunteers who are there to provide written information to help people find more about services in their own community. We have cancer liaison health professionals in 4 hospitals across New South Wales at the moment. We have survivorship programs, and particularly one that some may know is our Enriching Survivorship program, which introduces survivors to a range of nutritional information, involvement in physical activity, and we've heard today from a number of people the importance of exercise, practical information and discussion about adjusting to life following cancer treatment. And we also have our webinar program, and these are free seminars that are available on the web through the Cancer Council website,
for cancer survivors. And these webinars are always recorded, so if people do register, they will, if they are not available at the time of the webinar to attend, the link will be sent to them afterwards. And some of the topics that have run over the years, and we've had over 40 webinars thus far, are returning to work, looking at financial and legal issues, fear of recurrence, fertility issues, sex and sexuality, and exercise. And in fact, the next webinar coming up on the 17th of June does focus on exercise and cancer. So legal and financial services, and I know Marina touched upon this in her presentation. This particular program, or these services, are designed to help and alleviate acute financial hardship. We have a pro bono service which connects people who otherwise can't afford to pay with qualified professionals for free. A financial counsellor will advocate on the client's behalf about their debts, such as credit card bills. Financial assistance is a one-off support of $350 to go towards a utility bill or can be sent out as grocery, petrol or taxi vouchers. We have lawyers who assist our clients to create a will, a power of attorney, an enduring guardianship if they are otherwise unable to afford it. A financial planner can help people manage their assets such as mortgage during a change in circumstances which a diagnosis of cancer can certainly bring about. We have workplace advisors who can help in preparing people to return to work. They can work with them about creating their CV. They can also talk to them about becoming more confident in their interviewing skills or how to have conversations with their employers about their cancer. And we can also provide small business support, which can help manage a business with advice. Information resources, and we had the table in the foyer out there, which had just a very small range of our information resources, but we do have a very large range, and they are all available to have a look at on the Cancer Council website. So these are evidence-based information in a range of printed and online formats, which go through practical topics such as nutrition and exercise for cancer patients, as well as the cancer types and treatment types. As an example, we've got our Understanding Brain Tumours group booklet, which I think this is the only copy we've got left at the end of the day.
We send them out at every...
Oh, terrific, thank you, yeah. These resources are the core of our evidence-based information for those affected by cancer. They are written in an easy-to-understand way and come in a variety of formats. So they are in booklet form, as I've just shown. They can be accessed through ebooks. They can be accessed online to read online. We also have online fact sheets which can be downloaded and printed off. We have CDs, and we've had 2 CDs, our relaxation CD and our meditation CD on the table, but we now have our meditation and relaxation podcast. So that is available through anywhere that you find podcasts, and it's called Finding Calm Through Cancer. And we have a lot of other online content on our website, and it is quite easy to navigate through, so I would recommend that you have a look at that. And also we have, not part of our Understanding Cancer resources, but we have podcasts, and the 3rd podcast has just been launched this year. So the first podcast was The Thing About Cancer, and the next 2 are The Thing About Advanced Cancer. And these podcasts have really been growing in popularity. It's hosted by, all the podcasts are hosted by Julie McCrossan, who's a former ABC presenter and a cancer survivor herself. And she interviews and speaks with health professionals, other experts working with cancer, as well as people affected by cancer. And they are really terrific. Each episode goes for about 20 minutes, and they're very easy to download and very easy to listen to. Of course, the benefit is that you can listen to it anywhere, on your computer, on your tablet, on your smartphone, and are very, very accessible. And now to emotional support, and that's, I guess, where my passion is, and that's an area that I've been working in the whole time that I've been at Cancer Council. So throughout the cancer continuum, people affected by cancer and their carers can experience a wide array of emotions. So we consider the 13 11 20 line an emotional support service as well as an information service. And sometimes that is all the client needs, just to speak to a voice who has warmth, who has empathy, and who can provide information on the end of the line. And all of our supportive care services can be spoken to and referred by our 13 11 20 consultants. But we have our Cancer Connect program, and that offers one-on-one support for cancer patients run by trained volunteers. So they are all people who have had a diagnosis of cancer themselves, have undergone training, so that they have the skills to talk to people who are newly diagnosed. And it provides them with a unique understanding with practical information and emotional support associated with that shared life experience. It is available at diagnosis for people with early cancer. We don't have volunteers who provide support from an advanced cancer perspective. And it's up to 4 contacts. It's a free service, and people can refer themselves, and then one of our consultants will match that person with a volunteer who best suits the needs that that person is after at that time. The telephone support group program, and that is certainly the program that I have been working on for quite a number of years, specifically with the Brain Tumour group, but I also work with some of our other groups, and we have 7 groups, and they are mainly for people who have metastatic cancer or less common or harder to treat cancers. We also have a carers group, and we also have a bereavement group called Life After Loss. That's set up slightly differently, but that does offer a 6-week, once-a-week group for people who are bereaved from a cancer loss. So the telephone support group program is 1 hour on the phone twice a month. We have up to 8 people in the group, and there's 2 trained facilitators. And people can take part in this group wherever they are. All we ask is that they're in a quiet place. They can be sitting up in bed, they can be sitting anywhere in their home, they can be sitting in a car, they can be sitting outside, they can actually be sitting in a more public area as long as it's not too busy and there's that privacy where they can speak openly without the risk of being overheard. And the telephone group for people living with brain tumours is especially dear to me, and we actually had one this week. And it's a group where people come together, so it's for anyone in Australia, so we can have people join from any state or territory, and people come because they have that opportunity to speak to others who understand. And there's a lot of humour in this group, there's a lot of sharing, people talk about all sorts of issues around living with a brain cancer. Sometimes it's to get information, to ask questions about treatment or how people are feeling or dealing with side effects, but often it's just to be able to talk to others who understand what it's like. We also have a very active online community, and this offers people currently living with cancer, cancer survivors, families, carers, and the wider cancer community the opportunity to connect, share experiences, and find information and support in a safe and secure forum. So this is a 24/7 digital support. There are forums, there are blogs, there are support groups, and there's that opportunity to ask questions and receive information from other people who might be living with the same type of cancer. The Cancer Support Group Leader Program is another program that Kim and I work on, and there's many familiar faces in this forum today because people who work with support groups in New South Wales are able to come and attend Cancer Support Group Leader training, and Kim and I have been privileged to work with a few people in this room. Yes, thanks, Jerry. And we also maintain a database of New South Wales support groups. There's about 260 groups on it at the moment, and that is also accessed by our 13 11 20 staff. So if a caller rings up and is wanting a support group, they can find that information on the database that Kim and I work with. But our main relationship really is with the leaders, and we're there to support leaders, to provide training and to provide resources. We also have a cancer counselling program. So sometimes people affected by cancer, their families and carers need to talk to a professional counsellor about things that are going on in their lives. This service can be provided either face-to-face or via the telephone. The standard cost per session is $100, but however, people experiencing hardship difficulties or financial difficulties can be accessed via a financial subsidy. And again, this is a referral process through 131120, and people are able to receive up to 6 counselling sessions. And just to finish off, I'm just going to give you a case study of how one person has been helped by a number of our services. So we have an example of Julie. Julie is 36 years old. She's married with 2 children who are in their teens, and Julie's been diagnosed with an aggressive brain cancer and also is experiencing financial distress. So she's unable to work and has experienced a reduction in income and depletion of savings. She's in arrears on her utility bills. She has multiple credit card debts, and she is looking towards end of life and finding some aspects of dealing with that very hard to manage. Both Julie and her husband work full-time until her diagnosis, and due to her diagnosis, Julie, of course, can no longer work, and her husband has had to reduce his work hours to care for Julie as well as the children. Julie's used up all her leave entitlements and has become unemployed. So she was referred to Cancer Council by her social worker, and she was referred to 131120.